Good morning, everyone. I hope everyone is ready to get started. I'll give everyone a second to get back to their computer if they're getting that last cup of coffee or tea. I want to welcome everyone to our third virtual Self-Insurance Colloquium on Occupational Health Best Practices. My name is Narisa Patrick. I'm the Self-Insurance Program Manager for the Department of Labor and Industries. Today's colloquium should last about 4.5 hours. We will have a couple of 10-minute breaks. And as you may have heard the prompt from the system, the colloquium is being recorded today. We have a few housekeeping matters. Susan, can you go to the next slide, please? So as I stated, this colloquium is being recorded, the webinar is being recorded, and there will be access to it on the LNI website and the WSIA website in the future if you or someone you know want to watch the colloquium in the future. We are in a webinar setting rather than a regular Zoom meeting. And as a result, we have a Q&A window, but we also have a chat window. And so both options will be available at different times. If you should be able to see them on the bottom of your screen. If you don't, just hover your mouse around and they should pop up. You should have a toolbar that pops up at the bottom of your Zoom webinar window. You will use the chat option to notify us if you're having any difficulty with your audio. The chat option is being monitored, and there will be folks that will be able to help you and troubleshoot you as much as we can. And staff will also be monitoring the chat window for any other issues that you may have. Also, if you're only on the phone, please post your name in the chat window so that we also know, and maybe put the last 4 digits of your number so we can link the name with the number so that we'll know who all has joined us today. The chat option is available to attendees at the beginning of the webinar and during the breaks to interact with other attendees. The private chat option will not be available. So keep in mind, as I said, this is being recorded. That includes your chat log. So keep in mind, there's no private chatting in between folks. So if you put it in the chat, it will be available for everyone and it will be recorded for future viewing of anyone, everyone that reviews the webinar. Only use the Q&A function to ask your questions when we get to that point. There will be panels today, and the Q&A section is for asking questions. And again, the question logs will be kept. And so keep in mind, again, that that will be saved for future. We will also be monitoring it to try to answer your questions live if we can. Give us grace if we don't have the answer right away. We will save the answer and try to get a response to you as soon as we can. So if we can go to the next slide, please. As you know, here at the department, we are all about our safety measures and wanting to remind everyone to be safe. Weather is changing on us, although some days, you know, with the way the sun is out, we're not quite sure which way we're going, but we know that we're heading into colder weather. So as the winter comes, please remember to dress warm, wear your dry, loose-fitting layers to hold your body heat in, cover exposed skin. Remember to protect your face and your hands. Prevent falls by watching out for slips on ice and snow, and wearing sturdy shoes and walking at a slow pace. As I reminded my son the other day when he was playing in some leaves, remember leaves can also be slippery, so be careful walking across those that are still down on the ground right now as well. Also remember to winterize your home, install your insulation, weather stripping, storm windows, check your heating systems, check your pipes, and all of those things, and watch your shoveling if you have to shovel take breaks, be careful what may be hidden under some snow that you're shoveling, and all around just try to keep an eye out as our temperature changes, it's getting dark earlier, and it's getting colder. That is our safety tip for today. So if we can go to the next slide, please. So our WSIA and Department of Labor and Industries Planning Committee developed a mission statement this year, and you will see the mission statement on the screen. As it says, the Department of Labor and Industries Self-Insured Colloquium is a collaboration of the self-insured workers' compensation community to promote worker wellness by encouraging healthcare best practices, health systems improvements and innovations, and high-quality evidence-based medical treatment. The self-insured community, through the Washington Self-Insurance Association, collaborates with L&I to review updates on medical policy issues and occupational health best practices. So that is our mission statement that we've worked very hard developing. So with that said, we have a couple of names in the chat. Thank you both. And again, if you are solely on the phone, please put your name in the chat and include your last 4 digits of your phone number so that we can connect your name with your phone number. And for our first presentation, our first topic is going to be the main topic is long COVID. You can see a more detailed explanation. This topic will be presented. I will be introducing Dr. Janet Freely. She will present an overview on long COVID. Dr. Freely is a board certified physiatrist and professor of physical medicine in the UW Department of Rehabilitation Medicine. She currently serves as the executive director of UW Medicine's post-COVID Rehabilitation and Recovery Clinic and the vice chair for clinical affairs in the Department of Rehabilitation Medicine at the University of Washington. She conducts health services and outcomes research related to chronic pain and disability, and is the editor-in-chief of PM&R, the official journal of the American Academy of PM&R. So welcome, Doctor, and I apologize sincerely if I pronounced your last name incorrectly.
No, that was perfect. Thank you so much for the introduction. So I would like to share my screen. I think that's going to be easier. So let me get that set up here for just one moment. And if you could let me know if you are seeing my screen here.
We are seeing your screen, but we're seeing the, there we go.
Okay, perfect, great. Great. Well, thank you so much for having me here. And, this is a really challenging topic. So I really appreciate that you're spending so much time this morning on this topic. It's challenging for all of us. 30 minutes is not a lot of time to cover the breadth of what we know about long COVID. So I'm going to try to do my best, and I've included a number of slides that I may not be able to get to in this talk, but hopefully will be a good reference for all of you going forward. I have no specific financial disclosures related to this topic. I'm an employee of the University of Washington, and I do want to acknowledge the Coast Salish people on whose land the University of Washington sits. So my objectives today are really 3. I want to start by talking about the landscape and the context of post-COVID conditions, or long COVID, or PASC. I will spend a moment talking about terminology. And then I will spend a little bit of time talking about the pathophysiology and some of the data that we know about in terms of prevalence and trajectory of PASC. And I'd like to spend the bulk of the time talking about how we diagnose and what are some of the strategies that we've been using to help people with PASC, really with a particular focus on injured workers. So there are several caveats. I always start my talks with these. I think it's important to recognize that long COVID is a long-term public health issue. It's not going away anytime soon. So it's really important that we spend the time to understand it and to develop strategies to be able to treat it. And I think it's also important to acknowledge that we know a lot less than we believe. There has been an incredible amount of research that's come out over the last couple of years, but we still have lots of unanswered questions. And so if I come back in a year to give this talk, it might be looking very different than what it is today. And then we know even less about how long COVID affects many underserved populations, and I'll spend a moment talking about that as well. But it's important to acknowledge that much of the research that has been done has not been done on underserved populations. So there's even more that we don't know about those populations. So my perspective, as you heard a little bit in my bio, comes from several different places. Probably most importantly to this talk, I had COVID back in April of 2020, so very early in the pandemic, and fell in the mild to moderate category, recovered at home. But I continued to have symptoms for about 9 months. And at the time, it was right when we were just starting to understand that people were having longer term symptoms after COVID. So much of it was very confusing to me. I've been previously healthy. For those of you who know me, you may know that I'm a bit of an overachiever. When I gave birth to my daughter, I took voluntarily 2 weeks of maternity leave and went straight back to work. And that has always been who I have been. But this was something that was completely different that I had never experienced before. And many of the symptoms that I experienced are the same that my patients are experiencing. So I think that that's important to understand as we talk about long COVID. I am a rehab doctor. I am used to taking care of people with disabilities and chronic conditions, and I think physiatry has really stepped up as a specialty in terms of leading the way with treating people with long COVID because of this experience. And then I do a lot of research. So I come at this also understanding the importance of research and evidence in diagnosing and treating conditions. And so I use that as a lens to look through when I am thinking about long COVID. And then finally, I am an editor of a journal. So we have published a lot of work on long COVID. And so I've been able to have the opportunity to see what is out the studies that are being conducted and the kind of research that people are publishing. So just to spend a moment about talking about the landscape or the context, I participate in the American Academy of PM&R's multidisciplinary PASC collaborative. So this is a national collaborative, not just of physiatrists, but of people from all specialties, or many specialties that are involved in the care of people with long COVID. And so this is a collaborative of about 40 post-COVID clinics around the country. And we participate with the CDC and multiple patient organizations as well. And this collaborative, I think, has been important in terms of publishing data on the prevalence of long COVID, and also publishing guidance statements on the diagnosis and treatment of long COVID that we'll talk about a little bit later. And the AAPM&R has created a PASC dashboard with estimates of the number of people affected by PASC, and this is using data from Johns Hopkins. And this is now, I think, over a week old. But you can see that there are estimated to be over 28 million people in the United States affected by long COVID. One of the recent studies that has come out, this was a study that was done in Italy of people who have been infected with COVID, so over 700 patients that had COVID, and they looked at people who developed long COVID symptoms and those who did not, and compared them on a number of different factors. And one of the things that I found interesting, and I think is important to point out with this data, and I think this is consistent with what we're seeing, is that we are fortunately definitely seeing a decrease in the number of people who are developing long COVID, or the percentage of people who are developing long COVID with the different waves. So you can see here that almost 50% of people in wave 1 developed symptoms of long COVID. And now with, in this study, the sort of wave 3, the Omicron wave was 16.5, so a significant decrease. And then also we're seeing a significant decrease in the percentage of people getting long COVID who have vaccines. And so the more vaccines you have, the less frequent the incidence of long COVID. So that's very hopeful. But I think, as you all know, the sheer volume and number of people who are infected with COVID means that even with those smaller percentages, we're still continuing to see new cases of long COVID. And how does that translate to working age Americans? This is one estimate. Again, these are all estimates based on the best available data. For what that's worth. But it does suggest that there are, as I mentioned, over 30 million working Americans who have long COVID. So again, huge, huge numbers. So with that, I want to spend a little bit of time talking about terminology, and this is important to me. I think words, as an editor, I think words matter. There are many different names for long COVID. Initially, patients labeled the symptoms that they were experiencing as long haul symptoms or long haulers, and that's a term that patients coined early on. But you'll hear long COVID, you'll hear post-acute sequelae of COVID or PASC. And I will interchange using long COVID and PASC in this talk, as those are the two most frequently used terms now. My personal favorite is persisting symptoms post-COVID. I think that this better reflects to me what is happening with COVID, and I think allows for the possibility of recovery, which I think is also important. So what is long COVID or PASC? I've sort of meshed together the World Health Organization and the CDC definitions, but essentially now people are landing on a definition of persisting symptoms 3 months after initial COVID infection that can't be explained by other medical conditions. And I think it's important to recognize that in the CDC definitions of post-COVID conditions, it's acknowledged that symptoms can be new after recovering from acute COVID, or they can persist after the initial illness, and that symptoms may fluctuate or relapse over time. So there isn't one single trajectory after COVID. And then very importantly, that the lack of laboratory or imaging abnormalities doesn't invalidate the existence, severity, or importance of a patient's symptoms or their condition. And that we'll talk about is very important when we're thinking about long COVID. Again, in terms of the terminology, just a caution. I personally do not like terms that label people as a long hauler or post-COVID patient, because I do think that can shape somebody's self-identity and their culture. That it doesn't allow for room to improve. Once you're a long hauler, you're always a long hauler. So I personally like using terms like persisting symptoms post-COVID, because that does allow for that possibility of recovery and isn't labeling people in a way that could be harmful for them. I do want to acknowledge again that what we know about defining PASC and diagnosing PASC is really limited to a white population, and most of the clinics across the country in the United States, as well as the research studies, are primarily enrolling white people. And vulnerable populations are likely underrepresented in both the clinics as well as studies. And so this can lead to some inequities in how we define PASC and how we understand it. So just a plug that we need to continue to make sure to have more diversity in our research as well as in our clinical care. So, pathophysiology is a big topic, so I won't be able to do it justice today, but I do think it's important to understand some very basics about what the research is showing in terms of the pathophysiology, why this is happening. I created this slide now, gosh, over 2 years ago. It's largely still true, although I think that there's lots more research that's come out that has helped us to understand what's going on. There's research that suggests that there are some virus-specific pathophysiology changes. So there is some research that suggests that there may be some persistent viremia in some patients. I personally don't think that that's a big issue, but some of the emerging research is suggesting that it might be for some. And then I think a lot of the research is showing that most of the the impact of long COVID is related to your immune system response and inflammation that happens. And with that, I think associated with that immune system response, there's a lot of different things that are happening in terms of vascular endothelial damage, changes in the clotting cascade, there's autonomic dysregulation, and then reactivation of other viruses. So all really related and under the umbrella of the immune system response. There was one recent study that was done here in Seattle, collaboration with UW and other groups that looked at, did a deep dive of 309 hospitalized patients with COVID and looked over time to see whether they developed long COVID or not. And they collected a lot of data on these patients. And what they found was that there are some identified risk factors at the time of diagnosis that can predict the presence of COVID. Those included diabetes as well as a few other pre-existing conditions, a high viral load to begin with, the presence of Epstein-Barr virus at their initial infection, as well as some specific autoantibodies. So we're still learning about what this means. This was in a hospitalized group of patients, so more severe initial infection, and may not be representative of patients with mild to moderate COVID, but it does suggest that there are things that might identify early that could predict COVID. There's also been a lot of work that's been looking at that endothelial damage that happens in the blood vessels. We know that the way that that COVID attaches to cells can impact the endothelial linings, and the combination of the leaky blood vessels with inflammation seems to be at the root of some of the neuroinflammation that we are seeing clinically. There was a recent study that was published that looked at longitudinal neuroimaging of patients with COVID. So they had a matched sample of 400 COVID patients with COVID and 384 matched controlled. And this importantly did find that there was evidence of atrophy in cortical regions that were directly involved with olfactory processing. So although we aren't able to see changes in most people with our current clinical imaging, there are studies that are showing that there are actual findings on neuroimaging for patients that have had COVID and ongoing symptoms. Again, I won't spend much time here, but I do want to acknowledge that pain is a significant part of PASC, and there are some proposed mechanisms for this that have to do with the way that the COVID virus attaches to the ACE2 receptors and alters the renin-angiotensin system. So there are some mechanisms may explain why people have a variety of different COVID pain conditions. And then one of the more sort of hot topics that people are discussing now is some research that's come out of South Africa and the UK that has identified that microclotting, again, changes in the endothelial linings and the immune system mediated clotting cascade might be contributing to some of the symptoms with long COVID. There's a lot more research that needs to be done about this, in particular about what to do about this, but this does seem to be playing a part in at least some of the patients. And then the final point about pathophysiology that I want to make is just that we are not able to yet identify clear biomarkers in our standard lab tests, but there are now a number of studies that are showing that there are actual inflammatory biomarkers that look at again, the vascular changes that we're seeing in COVID. This is one example that showed that there in patients with long COVID, that in at least two of the particular biomarkers that they were looking at that are involved in angiogenesis were much higher in people with long COVID. There was another study that came out of UCSF that was published this year in the Annals of Neurology that was able to identify some serum biomarkers in people with some of the neuropsychiatric symptoms as well. They were looking at some of the nerve cell proteins. So, and the RECOVER study is a national study that's funded by the NIH that is ongoing now. Probably the largest study of long COVID. And again, they're doing a very deep dive of patients with long COVID to understand what some of the trajectories and the biomarkers are. And in some of the early work from that and other studies here in Seattle have shown that there are some inflammatory biomarkers they're able to identify. But unfortunately, we aren't able to translate that yet into clinical practice. I do want to caution people that there are a lot of private companies out there across the country that have marketed directly to patients to take their blood and identify some markers of long COVID. These really don't have the evidence to back them up. They are very costly for patients and they produce a lot of data, but it's impossible to interpret that data. So just a caution that the patients are seeking those and those are being directly marketed to patients inappropriately. So one of the big questions when we think about the pathophysiology of PASC and what we're seeing is, have we seen this before? And this is a big question that everyone asks. And certainly we have seen many post-viral conditions in the past. So some of this is not new. Some of this is unique to COVID and the specific ways that COVID attacks certain cells and how it behaves in the body. But certainly there's a generalized immune system response that is something that's similar that we have seen in other post-viral conditions. If you look in the literature about Icelandic disease, for example, was one many years ago that was very similar to what we're seeing in the post-COVID condition. So certainly not entirely new. And there's a lot of overlap between PASC and other conditions that we're well familiar with. ME/CFS, chronic fatigue syndrome, POTS, postural orthostatic tachycardia syndrome, and then mast cell activation syndrome all have sort of overlapping symptoms and pathophysiology. And so there's a lot of overlap between post-COVID and these conditions. So just talking about the presentation of PASC, we've talked a little bit about who's at higher risk for PASC. I just want to re-emphasize that from the data that we have, that people who are unvaccinated are at higher risk. But we also know that people with a variety of medical conditions are also at higher risk for developing PASC, including conditions like anxiety and depression. And we'll talk a little bit about that. I want to present very quickly a common outpatient clinical case. This is not an injured worker, but this very well could be, and is very representative of the kinds of things that we're seeing in our clinic, and I'm sure that many of you have encountered in your work as well. So this is a 35-year-old previously healthy fitness instructor who developed COVID about a year before he saw us. He had a mild infection initially. His symptoms improved, but then over the course of 3 months, his symptoms got worse. And when we saw him, he really had about 9 months of fatigue and myalgia that were constant, but were definitely worse with exertion or after exertion. He reported that his heart rate was going up even to much higher than expected, even when walking to the kitchen and low intensity activities. And then had a variety of other symptoms, brain fog, insomnia, new food sensitivities that he didn't have. And importantly, he was feeling very anxious and hopeless. He was worried he would never recover. He was very confused by what was going on. He wasn't able to return to work as a fitness instructor given his symptoms. And he really felt that his previous clinicians didn't believe his symptoms were real. So he was very frustrated and felt very hopeless when he saw us. And this is a slide that I use when talking with patients oftentimes, and I think it's helpful to explain how many of these very disparate symptoms actually can be part of the same complex. And so for patients, they might think, oh gosh, I have something wrong with my lungs, or I have something wrong with my lungs and my heart and my brain. And they think of it as a very organ specific problem. And so they're seeking out specialty care from each of these different specialists, only to find that there's nothing wrong with their lungs, there's nothing wrong with their heart, there's nothing wrong with their brain, but they continue to have all of these different symptoms. So I think this is a way to help put it in perspective that all of these different symptoms are likely related to inflammation, more systemic inflammation, nervous system dysregulation, and that disrupted immunity. And this can be helpful for patients to understand this. I won't spend much time talking about this, but this was one of the biggest initial cohort studies of over 3,000 patients internationally with PASC, and they identified, which is very consistent with what we're seeing in the clinic, that the majority of people experienced fatigue, post-exertional malaise, and cognitive dysfunction, and those are really still the three probably most important symptoms that we're seeing in the clinic. We also are seeing a lot of COVID pain. I mentioned there's some proposed pathophysiology for this. But it's very common. More than 50% of our patients are experiencing pain-related conditions and a variety of different pain concerns. In talking about mental health, and I think this is important to point out, there's definitely research that is suggesting that first-time mental health diagnoses increase after COVID. And this one particular study found that in comparison to the flu, COVID had a much higher probability of new diagnoses of psychiatric illness, mood disorders, and anxiety disorders. And certainly we are seeing a very high percentage of our patients are experiencing new anxiety or worsening anxiety after COVID. So, does long COVID cause anxiety? I would say yes, it does. I think what's important to recognize is that that long COVID can exacerbate pre-existing anxiety, but it also can cause new anxiety. I was one of those people that had never experienced anxiety before. And for about 9 months, I had very significant anxiety that was a very physical anxiety that came about when my heart rate would start becoming unstable, and it would cause a very physical sense of anxiety. So, and that's what a lot of my patients are describing. And I think the other thing to recognize is that patients are very anxious about the impact of long COVID on their health and their change in their function. They have significant financial concerns, especially when they're not able to go back to work or go back to work in the way that they were. And this causes a lot of stress within their home. So I just want to reemphasize that long COVID is not caused by anxiety or depression, although these are risk factors for developing long COVID, and they can make the recovery more difficult. So this is really a critical part of what we do in the clinic, is to assess for anxiety. As you all know, long COVID definitely impacts ability to go back to work. And so this is one of the things that we spend a lot of time talking about in our clinic, is how to get people back to work. There are lots of different relapse triggers. I think you're probably all familiar with these, but physical and cognitive exertion are very common triggers of relapses. And so I think these are important to keep in mind, especially when thinking about people returning to work and how to avoid relapses of their symptoms, or try to minimize situations that are going to cause relapses. So helping patients to understand what their own triggers are and figure out strategies to be able to minimize those is really important. So, how do we evaluate and manage PASC in our clinic and in our consortium around the country? Well, let's go back to that common clinical case, this fitness instructor that was having fatigue and post-exertional malaise. When we saw him in the clinic, his exam was fairly unremarkable, as most of them are. Things that were significant for him was that his pulse at rest was 101, which is more than what we would expect from a healthy 35-year-old fitness instructor. And when we did orthostatic vitals in our clinic, what we saw was that his blood pressure was stable from a lying down position to a standing position, but his heart rate increased from 85 to 120 and triggered some of the symptoms that he was experiencing. And he appeared, anxious. He definitely had moderate depression and anxiety on our screening tools in clinic. So with a patient like this, there is a very broad differential diagnosis, and this is what is so challenging in evaluating people with long COVID symptoms, that there are many, many different things that can cause those symptoms and the signs that we see in our physical exam. And one of the most important things that I think of is that, we really can't formally diagnose PASC without ruling out other etiologies. So it does actually take a fair amount of work to sift through what's going on and make sure that there aren't other things that could potentially be causing it. So it does require some workup, and maybe more extensive workup than we would like to do or feel that we normally would do in order to rule out other conditions. One of the things that we have started to do in our clinic is to think of easy ways in our clinic to assess for some of the common things that we're seeing in a way that doesn't tax the healthcare system. So when somebody would present with symptoms that we thought were consistent with POTS or POTS-like symptoms, orthostatic tachycardia, like our patient did, we in the past might send them to neurology for an full autonomic testing to really assess for autonomic dysfunction. Now we do a 10-minute Nassau lean test in clinic, which is essentially orthostatic vitals over a 10-minute period. And this has been extraordinarily helpful in our clinic to identify people that have just wild changes in their heart rate from a lying down to standing up position, and can be really helpful to identify autonomic dysregulation in a very inexpensive and easy way. For this patient and all of our patients that have this orthostatic tachycardia, I really caution, as you heard, I don't like labeling people. I never label people with POTS. And I think that once you label somebody with POTS, they can often enter this downward spiral of decreasing their activity, getting deconditioned, and worsening their symptoms. So I think it's important to recognize that autonomic instability, that the heart rate and blood pressure instability that we're seeing after COVID definitely tends to improve and resolve with time. And there are some treatments that we can use in the meantime to help with their symptoms. But labeling somebody with POTS that then carries forward for the rest of their lives, I think, is doing them a disservice. In terms of how to treat the symptoms that we're seeing, as I mentioned, I'm a publisher, or I am an editor-in-chief of PM&R. And we have published through the PASC Collaborative a number of different guidance statements on many of the common symptoms that we're seeing in post-COVID conditions. This one is related to autonomic dysfunction. And I like these because they have very clear tables that have standard workups that you should consider doing that are evidence-based to the best of our ability. And then they have tables that identify treatments, and many of these treatments are behavioral treatments, things that are easy to incorporate into clinical care. But there are some medications that can be helpful for patients, and we draw on research that's been done in other conditions to apply to PASC. So those are a good resource for people. I know I'm running out of time here, so I just want to spend a couple of minutes talking about our clinic in particular, and my approach and some pearls. At the UW clinic, I think what focuses, what I think of with patients and my approach is that we really focus patients on a path to recovery instead of a path to long-lasting disablement. And so that does require us to take a holistic approach that really uses a biopsychosocial model to help patients to recover. So just very brief overview of what we do in our clinic and some common things that we see. One is that there's no universal treatment of post-COVID symptoms yet, and that patients do present very differently. So we have to tailor our treatments. And some of it is trial and error. The treatments currently are symptom-based, and we really focus on using safe and effective rehab strategies that we've used for other patient populations, a lot of self-management and behavioral strategies. But we also do use medications and other treatments that are safe. I have mentioned that you have to keep in mind alternative diagnoses and comorbidities that can contribute to the symptom. And then very importantly, we have to validate patients' concerns. We have to acknowledge what we don't know yet. We have to encourage patients to participate in research to help, but we have to really help them understand that we know that they are experiencing these problems and that the problems are very real. We offer a lot of reassurance and hope in our clinic. And then one of the sort of pearls that we have learned is that when we see patients back frequently, we follow up with them every month to every 2 months. They tend not to start shopping around to multiple different specialists, and they consolidate their care with one provider, which I think is really important. So this has been a good strategy to minimize overuse of specialists and some of these ineffective treatments. And as I mentioned, there are a lot of lab panels, and there are a lot of very expensive treatments that people are seeking. I've had patients go overseas to get all sorts of very expensive and potentially harmful treatments. So it's really important to talk to patients about what is out there, and patients really are pretty desperate at this point for treatments, and so may seek some of these treatments that are not evidence-based and can potentially be very harmful. As I mentioned, we use a holistic approach in our clinic. We address mental health. We talk a lot about nutrition, sleep, and restorative exercise. And then one of the things that we have found to be particularly helpful in our clinic is that we use a series of 6 telemedicine rehab psychology-led groups that again help patients to focus on some of the self-management strategies for a variety of their symptoms. And this has been one of the most successful things in our clinic, and patients love this, and they have really get a lot out of this and feel like this is one of the most helpful things that the treatments that they receive. We do use medications in our clinic, and we tend to use medications that are safe, that we have a lot of experience with, and other conditions that have similar kinds of symptoms as long COVID. We are not using a lot of the experimental medications that potentially are very harmful, but we have found that many of the treatments, and especially the ones that I list here, have actually been very there are over 50 different ongoing trials of different treatments for COVID. So I think next year we'll see that we'll have a lot more information about what is effective and what's not effective. So again, if you bring me back in a year, I may have very different information. And then, this is sort of preaching to the choir here, but I do think that it's important to provide patients with support for work accommodations, and understanding that relapsing and remitting course of long COVID and some of the triggers of worsening symptoms is really important, and incorporating some strategies to deal with these triggers into their return to work plan, I think is really critical for success. So just to wrap it up, as I know I'm over time, some the things that I have learned about treating patients with long COVID over the last 2.5 years. No 2 patients have the same symptoms or the same course. We have to listen to patients' story to really understand how to best treat them, and it does take some trial and error. But we are seeing a lot of patients get much better. I think there's a lot of hope for these patients. And I think importantly, the other thing to remember is that COVID lights everything on fire. So it's like lighter fluid. So anything that a patient had before COVID and anything that they were predisposed to, COVID is just going to light that on fire. So I think that's one of the challenges for you, is to think about when you're thinking about how to deal with these workers' compensation claims is understanding the relationship between what is new and what is pre-existing, and how COVID may affect some of those pre-existing conditions and what to do about that. Okay, so I will end here, but hopefully we will have time later to have questions, and feel free to reach out to me at any time with questions.
Thank you, Doctor. That was very much appreciated. I'm sure that a lot of folks that are listening in learned a lot of things just as I did. So I very much appreciate your presentation. And if you are able to stick around, I'm sure that when we get to one of the breaks, you know, folks may have questions at that time. Our next presentation is now discussing, now that we've heard, you know, more about long COVID, looking at long COVID in Washington workers' comp. And so during this presentation, we will hear from Dr. Nam. Dr. Nam is Associate Medical Director at the Department of Labor and Industries. She will give a presentation on workers' compensation and long COVID. Dr. Nam worked as a hospitalist at Thomas Jefferson University Hospital in Philadelphia for 2 years, followed by 3 years at Swedish Medical Center in Seattle. She completed an occupational and environmental medicine residency at UCSF this June and joined LNI in August. Danielle Todorov from LNI's SHARP program will present some LNI data, followed by a Q&A session. Danielle is an epidemiologist with the LNI SHARP research program. Her research focuses on occupational respiratory diseases, including asthma, toxic chemical inhalations, and COVID-19. She's part of a multi-state work group for occupational COVID-19 organized by CDC, NIOSH. So I believe that Dr. Franklin, or excuse me, Dr. Nam has been promoted up. Is that correct? Are you ready, Doctor?
Yes, I'm ready. Thank you for the introduction, and thank you for the great talk, Dr. Friedli. Then I will start my screen sharing. Thank you. And can you see my slides?
Yes, we can see your slides. You want to go? Yep, there we go.
Yes, thank you. So today I would like to present about long COVID in Washington workers' compensation system today. And my topics include the general updates and challenges of long COVID, including causation analysis, mental health aspect, and return to work process. At the present, there are so many things that we do not know and do not have answers about long COVID, but numerous researches are ongoing to find out the underlying mechanism of long COVID in hope of developing effective treatment once the etiology becomes clear. And first, I would like to summarize the federal government's response on long COVID to accelerate scientific research and to providing support to affected individuals. And there were 2 reports released this August. The first report, Services and Support for Longer-Term Impact of COVID-19, outlines federal services available to the public with a focus on supporting individuals facing challenges related to mental health, substance use, and bereavement. And the second report is National Research Action Plan. And this research action plan lists research priorities, including developing diagnostic strategies and effective treatment plan. And WHO published their clinical guide definition of post-COVID-19 conditions about a year ago. And these 2 domains are notable as SARS-CoV-2 laboratory confirmation and symptoms that cannot be explained by an alternative diagnosis. And there is proposed rulemaking ongoing at this time in Washington State for the verification of presumptive coverage. There are challenges related to long COVID, and I'd like to introduce this newly published article about it. This study is a qualitative analysis using health records from national random sample of 200 veterans who had COVID infection and had the diagnosis of long COVID. And the authors pointed out two major issues, which are clinical uncertainty and care fragmentation. With clinical uncertainty, it is often hard to tease out which particular symptoms are due to long COVID in the setting of multiple coexisting pre-existing comorbidities and underlying functional limitation, which often led to additional diagnostic testings and more specialist referrals. And with the care fragmentation among primary care, specialist care, and post-COVID clinic, which often led to limited care coordination, resulted in duplicated care, which can be burdensome and confusing to patients. And the conclusion of this study was that we need more integrative, person-centered long COVID management. And this is the table showing the baseline characteristics of these 200 veterans. And their mean age was about 60, and 54% were older than 60, and 86% were men. Of note, 42% of them had underlying major depressive disorder, and 27% had underlying post-traumatic stress disorder at baseline. And now I would like to discuss a clinical case with you. She's a 40-year-old nurse, resident care manager who has long COVID with brain fog, dizziness, headache, insomnia since COVID infection about a year ago. And she has underlying obesity and history of anxiety with panic attacks and asthma. Since COVID infection, she had multiple ED visits with episodes of shortness of breath, palpitations, and panic attacks. And she reported worsening depression, anxiety, insomnia, and gained about 20 pounds due to reduced activity at home from fatigue and post-exertional malaise. And she was recently diagnosed with POTS, which is postural orthostatic tachycardia syndrome, and orthostatic hypertension. And also she was found to have new onset obstructive sleep apnea, hypothyroidism, and sinusitis, which are attributed to long COVID. There are many causation challenges related to COVID, long COVID. And it is often hard to know which particular symptoms or conditions are due to long COVID or not. And often there is no available information on pre-existing conditions, and there is overlap between long COVID and underlying chronic fatigue syndrome or fibromyalgia. And many times there are subjective symptoms without objective findings. And existing medical literature have some quality concerns, making it hard to establish causal relationship between long COVID and various health conditions that are attributed to long COVID. And this figure shows the hierarchy of medical evidence and systematic reviews and randomized controlled trials at the top means they have higher quality of evidence with lower risk of bias. For the studies on long COVID, many are either expert opinion or case report or case series, though limited number of them are controlled cohort studies or uncontrolled cohort studies at this time. NIOSH and ACOM steps are the most often used method to determine the work-related needs of disease. And I would like to apply these steps on our clinical case. Of note, these steps need to be followed in order, and failure of one step means stopping the process of further evaluation. First, we'd like to answer whether she has newly diagnosed POTS or orthostatic hypertension. And step one is to identify the evidence of disease. And the right-sided table shows the diagnostic criteria for common autonomic disorders, and it's from AAPM&R, multidisciplinary PASC consensus collaborative guidance, which are very helpful resources for common PASC conditions. And based on the table 1 diagnostic criteria and medical records review, she had negative tilt table test and negative standing test and did not meet the diagnostic criteria for POTS at this time. But if she had a confirmed diagnosis of POTS, the step 2 is to review and assess the available epidemiologic evidence for a causal relationship. And this step involves comprehensive literature review and evaluating the quality of medical literature. And there are more and more articles and studies on long COVID are coming out, which are welcoming. However, discerning the quality of medical evidence is important. And this figure shows common neurologic symptoms related to long COVID, including autonomic dysfunction. For remaining steps, step 3 is to obtain and assess the evidence of exposure. And in our case, it is about the laboratory confirmation result for the COVID-19 infection. And step 4 is to consider other relevant factors. For example, to answer the question whether her new onset obstructive sleep apnea is secondary to long COVID, we would consider relevant factors and ask these questions, such as, is her obstructive sleep apnea pre-existing undiagnosed condition, which was found due to increased testing for evaluation for her insomnia and fatigue? And is her obstructive sleep apnea aggravated by recent weight gain? And what are her underlying risk factors for the sleep apnea? Oftentimes, there are subjective symptoms with no objective findings in post-COVID conditions. And there are some tools that can be helpful to monitor and evaluate these symptoms. For example, 6-minute walk test for reduced endurance, and PHQ-9 or GAD-7 questionnaire for mood symptoms can provide valuable insight on the severity of these symptoms. And our case continued as she reported ongoing fatigue, dizziness, poor sleep with worsening depression and anxiety at her follow-up visit. And the provider noted that anxiety has been a big issue, and she worries about her health and whether her symptoms would get better. And now I would like to discuss 2 studies about the relationship between long COVID and mental health. This study explored the relationship between pre-infection psychological distress and the risk of developing post-COVID conditions by doing periodic surveys from April 2020 to November 2021. And the conclusion of this study was that pre-infection psychological distress may be a risk factor for post-COVID conditions. pre-infection probable depression, anxiety, worry about COVID-19, and stress were associated with 30 to 50% increased risk of developing self-reported post-COVID conditions and related daily life impairment. However, the authors cautioned against misinterpreting their study outcome to support a hypothesis that post-COVID condition is psychosomatic. And this study looked into the risk of mental health outcomes in people who had COVID infection. By comparing cohort to 150,000 people who had COVID infection to two control groups, one contemporary and one historical control groups, each over 5 million people, using the data from the Department of Veterans Affairs. And what they found was that there is increased risk of instant mental health disorders in COVID cohort group. For example, COVID cohort group had 35% increased risk for anxiety disorders and 39% increased risk for depressive disorders. And for the increased risk of mental health outcomes, it was even evident, even people who are not hospitalized during their acute COVID infection, though the risk of mental health was highest among people who are hospitalized during their acute COVID infection. And these two studies suggest that there is bidirectional relationship between COVID-19 infection and mental health. Our case continued as at her most recent visit, it was noted that she finished sessions of physical therapy, speech therapy, and cognitive behavioral therapies. And providers noted that she remains pretty stressed and worried about her future work potential as she's been off work for a year. And she is worried and has increased anxiety and concerned that her symptoms would interfere with her work and would get worse with working. Common symptoms such as fatigue, post-exertional malaise, and brain fog affects a person's ability to work and their work capacity. And many workers often required and needed reduced work hours or modified work duties. And there are several barriers related to return to work process. The availability of job accommodation, such as availability of modified duty at their workplaces, and physical deconditioning, including post-hospital syndrome, are two major factors related to return to work process. In addition, psychosocial factors such as catastrophic thinking, symptom exacerbation fears, and disability belief has significant role in return to work. The right-sided graph showing the relationship between time loss duration and disability status remind us the importance of the early intervention measures to prevent disability from post-COVID conditions. Though we do not have proven methods on how to prevent disability from non-COVID, there are known concepts and some tools that can be helpful to prevent disability from non-COVID. The SPICE model emphasized concepts such as simplicity, meaning conditions treated in complicated fashion becomes complicated. Proximity, meaning that being away from work for a long time make it harder for a worker to return to work. Immediacy, centrality, and expectancy. as set a positive expectation for recovery and providing reassurance. Activity coaching is a voluntary 10 weeks program focusing on incremental activity advancement while addressing psychosocial barriers. And there is large overlap with current PCC guidelines, such as keeping activity log and using 4P strategy, which are planning, pacing, prioritizing, and positioning. And we plan to utilize these programs for our workers with post-COVID conditions. And there are ongoing activities and plans at the Office of Medical Director at this time, including weekly long COVID work group meetings and presentations utilizing internal and outside resources to prevent disability from long COVID, and collaboration with the SHARP researchers and connecting with outside experts. And I am thankful to our work group members as we continue to learn from each other's perspectives and experiences. Thank you very much for the attention.
Thank you, Dr. Nam. Danielle, I see you are on. Do you want Susan to present your slides? She can present them and and forward them for you.
That would be good. Okay. So the SHARP team within LNI has been conducting post-COVID condition research for about a year now, and we're ready to discuss some of our results. I want to note, though, that this is still a highly active research project, and these results may be subject to change as we prepare for our final reporting at the end of this year. Next slide, please. So starting with our data source, since the beginning of the pandemic, SHARP has been conducting surveillance on COVID exposures in the workplace using our workers' comp system. And if you want more information on this, I have a link to our reports at the end of the slides. The data we've collected through this existing surveillance system is the primary data source for our post-COVID conditions research. And some additional information on race, ethnicity, hospitalization, and ICU status comes from a research partnership with the Department of Health. We routinely link their contact tracing data with our COVID-19 claims. And the data I'm presenting today is current up through March 2022. Next slide, please. So as we've seen so far, there are many possible case definitions for long haul or post-COVID conditions. We are using the CDC's case definition because they are a primary funder of this research, and we want to stay comparable with what other states are doing. So their case definition uses a symptom duration of 28 days after the onset of illness, and these symptoms can go away and come back again, as we've seen so far. So we've modified this case definition a little bit to meet our research goals. So our case definition is that occupational post-COVID conditions occur in individuals with a history of COVID-19 exposure at work and 28 days or more of symptoms after their first positive laboratory test. Next slide, please. So here's our workflow. We start with a cohort of around 12,000 COVID claims with exposure at work and a positive lab test. We accept rapid, PCR, or antigen tests as proof of positivity. We also include accepted and rejected claims since our goal is to estimate the overall burden of disease. Now, unfortunately, we don't systematically record symptom duration for all COVID claims. To work around this, we pull COVID claims that had indicators for 28 days or more of symptoms. These indicators are things like 28 days of paid time loss or 28 days of medical services after their positive test. We call these suspected cases. So we have around 1,600 suspected cases. Now, these indicators are rough. There are many other reasons why a claimant might be out of work for more than 28 days, such as the closure of a facility due to a COVID outbreak. So we have to go into the claim documents and manually review the medical information to confirm the symptom duration and build a return to work timeline while we are at it. We reviewed 835 claims. Note that this is only half of our suspected cases. We were only able to review half due to limited staff resources. We will be extrapolating our results from this half that we have reviewed. If the suspected case is found to have at least 28 days of symptoms through this manual review process, we call it a confirmed post-COVID condition case, and we have 358 of them. So what counts as a post-COVID condition? So long as a physician doesn't challenge the link between the ongoing symptom and the COVID infection, we count it. We are not attempting to define a post-COVID condition for ourselves. We're more interested in the impacts on return to work. Next slide, please. So our first goal was to get a general estimate of the prevalence of post-COVID conditions in our cohort. However, incomplete data led us to severely underestimate cases among self-insured employers. Self-insured claims were less likely to be captured as a suspected case, and upon review, often lacked the medical documentation needed to confirm the symptom duration and confirm that it truly was a post-COVID condition case. So 71% of the self-insured cases that we reviewed had insufficient medical data to classify them, compared to only 27% of the state fund cases. Next slide. So when we give our final prevalence estimates, we give them as a range in an attempt to overcome the undercount from self-insured. We believe that between 6 and 9% of work-related COVID claims with a positive test will go on to develop a post-COVID condition. This corresponds to between 717 and 1,100 total cases in our cohort, which, to reiterate, is claims established up to March 2022. Next slide. To compare this with what the CDC is estimating, at 1 month post-infection, the CDC estimates that 13% of all COVID cases have a post-COVID condition, a bit higher than our estimates of 6 to 9%. However, at 3 months post-infection, the CDC estimates that 2.5% of all COVID cases continue to experience post-COVID conditions. And we estimate this to be between 3 and 5%. So while we underestimate the number of post-COVID condition cases with shorter durations, we are roughly in line with the CDC on these longer lasting post-COVID cases. This is reassuring to us since this is a period where conditions get diverse and complicated, and we start to align more with other case definitions, such as the WHO's, which require a minimum duration of 3 months of symptoms anyway. Next slide, please. So for the rest of this presentation, I will be only talking about our confirmed post-COVID condition cases and simply refer to them as a case for simplicity. So 91% of our cases were compensable and 96% were accepted. Cases have a median of 4 months of paid time loss and a median total claim cost of $25,000. Note that the ranges on these stats are huge. Some cases are short and cheap, other cases are long and complex. Next slide, please. Cases had a median age of 49 years and were 72% female, mostly filing in English. Only 4% of our cases used another language. Half of our cases reported comorbidities. A third were hospitalized, and a quarter required ICU care, according to the DOH's contact tracing data. These were much higher hospitalization and ICU care rates than in our cohort overall. Next slide, please. We observed 3 fatalities among our cases. 2 fatalities were due to restrictive lung disease, and 1 fatality was due to a suicide following prolonged course of debilitating labyrinthitis. Next slide, please. 73% of our cases were still off work after 28 days of illness. After returning to work, 17% of cases required a reduction in hours, and 12% required job modifications. Modified duties include increased breaks, no heavy lifting, no patient care, and these were often due to things like post-COVID cognitive impairments. Now, this is what the workers were prescribed to do by their physicians. It's difficult to determine if these guidelines were being always respected by employers. 4% of confirmed cases attempted a return to work, but were taken off duty again due to post-COVID symptoms. All of this to say is that the return to work experience for post-COVID conditions is complex. It ebbs, it flows. It's not a one and done thing. Next slide, please. Our top 5 most commonly reported post-COVID condition symptoms were, unsurprising, fatigue, dyspnea, cough, headache, and chest pain. The most surprising thing is the duration of these symptoms and their effect on return to work. Half of the cases reported fatigue after 28 days of illness, and this fatigue had a total median duration of 84 days, nearly 3 months. And 67% of workers reporting fatigue after 28 days of illness were still off work. 3/4 of workers reporting dyspnea after 28 days of illness were off work. And dyspnea is closely tied to other symptoms such as exercise intolerance, dizziness, mobility impairment, and anxiety that make it difficult for workers to return. Workers with headache report a median duration of 107 days of the symptom, and they may also experience light and noise sensitivity. Next slide, please. Among hospitalized workers, the top symptoms are the same, but we also see other things such as muscle weakness and exercise intolerance that may be related both to the symptoms of post-COVID conditions, as well as the prolonged bed rest from their hospitalization. 1/4 of hospitalized workers were discharged with supplemental oxygen. This may prevent them from returning to work unless they have a purely sedentary job or other accommodations. Next slide, please. After 60 days of illness is where the symptoms really start to diversify and things get more complicated. And this slide kind of undersells the complexity because we can't really put it succinctly in a single place. After 60 days of illness, 7% of cases are still experiencing brain fog. To position this, that would be around 50 claimants overall. Not a huge number, but this is still a major impact on their day-to-day functioning. And brain fog often co-occurs with things like sleep impairments, as well as more rare symptoms such as severe anxiety or PTSD from traumatic hospitalization experiences. However, it appears that the majority of cases with brain fog are working. By comparison, the majority of workers with deconditioning are off work. This is a major barrier, especially among older workers or those who don't have light duty available to them. 6% of cases report memory impairment after 60 days, and the majority were off work, a much higher rate than just brain fog. And among those who are working with memory impairment, 78% of them required job modifications, such as no patient care. And we look forward to exploring these things more in depth in our final reports at the end of this year. Next slide, please. That's where I'm going to leave off for now. Here are the resources that we cited in this presentation. Next slide. And I'd like to thank my team at Sharp, Carolyn Whitaker and Elliot Martin, as well as our partners at CDC NIOSH for their funding and their support. Thank you.
Thank you so much. Our next, oh, I apologize. I just lost my screen here.
Looks like Dr. Franklin has his hand raised.
Oh, Dr. Franklin. Thank you.
Thank you. I'd like to ask Danielle, are you still there?
Yes.
A question. So could you just talk for a minute about why Sharp picked the 28 days instead of the CDC definition, and also what you see as the main advantages and disadvantages of doing the 28 days versus the 90 days?
Yeah, so the 28 days came from the CDC definition at the time that we started the project, which was a minimum of 4 weeks of symptoms after the onset of illness. And we did this because we're collaborating with other CDC NIOSH funded states. And we hoped that our data may be comparable between us, but that was the general intention. But also we thought workers' compensation is a specific system, and the data it collects is not complete. And so 28 days might kind of open the doors to more diverse situations. So we can go in and review more different claims and see what was going on.
Thank you.
Thank you. So our next presentation, there will be a panel discussion on the clinical aspects of long COVID. We will have two different panels today. One will be this panel that's coming up regarding the clinical aspects of long COVID. And then we will have a break and we will then have a panel discussion on the legal and adjudicative aspects of long COVID. So there have been at least one question posed in the Q&A, and I indicated that that question will be posed to the panelists during the Q&A session for the panelists. So I'm going to introduce Dr. Franklin. Many of you, I'm sure, know Dr. Gary Franklin. He's the medical director here at the Department of Labor and Industries. He will be moderating this panel discussion on the clinical aspects of long COVID. Dr. Franklin has served as the medical director of the Washington State Department of Labor and Industries from 1988 to the present, and has more than 25-year history of developing and administering workers' compensation healthcare policy and conducting outcomes research. And the panel members will be Dr. Janet Friedley and Dr. Nam. Questions, as I said, will be selected from the Q&A and answered by the panel members. So if you have any questions, feel free at this point to put them in the Q&A. And like I said, after this, we will also, if they apply to the legal or adjudicative panel, we'll also have a break in between where we will also take additional questions for that panel. Dr. Franklin?
Okay, thanks so much. And thank you, Dr. Friedley and Dr. Nam, really fantastic talks. There's already a question from an anonymous attendee, which is, other than a positive COVID test, there's usually no other guidance to remove a worker from employment. How long is it suggested we keep them off, even with no other physical finding and mostly subjective symptoms? You guys have any thoughts on that?
I might need some clarification. This is talking about acute COVID, or this is someone with a post-COVID, long COVID diagnosis?
I think this is not necessarily a long COVID question. It's because we have some, we've accepted most of our COVID cases. So they're off work, and the question is, how long should they stay off work with no other physical findings and mostly subjective symptoms? I think, what I heard you all say is this panoply of symptoms is very real for most patients. And what I took away is the burden might be more or less on us to have a reason to not let them be off work or to accommodate them. That if they really had COVID, positive test, et cetera, and now they have this constellation of symptoms, it would seem burdensome on the worker to say, well, that's not really related. And I mean, that's what I'm hearing you guys say. Is that correct?
I mean, certainly from my perspective, it is. So I'll preface what I'm going to say, in that, you know, as a treating physician, for me, I look at all of their symptoms and everything that is contributing to what their experience is, and so me trying to sort out which of the symptoms may or may not be directly linked to their work-related injury doesn't really matter to me as a treating physician, because I'm going to treat all of the things that are contributing. And so I can say that it's burdensome for the physicians who are treating to have to say, well, gosh, you know, they're not sleeping, the insomnia is contributing, and the sleep, non-restorative sleep is contributing to their symptoms. We know that that's contributing to their fatigue and their cognitive symptoms. So we have to treat the sleep, but we also know that they have symptoms, potential symptoms of sleep apnea. Are these symptoms that the patients are reporting new symptoms, are those directly related to COVID or not? And then sorting through that in the clinic visit is really challenging as a treating physician. And from my perspective, I don't when I'm treating a patient, I don't care if it is directly related. I just know that it is impacting their symptoms, and so I need to do the appropriate workup and treatment. So I think that's the challenge from thinking about it from the physician side versus the coverage side, and where there oftentimes are sort of conflicts and trying to sort that out. It's a challenging situation for you to figure out what things to attribute to the to COVID directly, and what things are exacerbated pre-existing conditions or things that they were at risk for before that are now manifesting now. So I don't know what the right answer is, but I know it's challenging. In terms of whether somebody should go back to work when they have these ongoing symptoms, I think what we have learned from acute COVID, and I'll use myself as an example, is that the people that I'm seeing in the clinic that tend to have more of the symptoms and sort of the spiral are people who didn't take the time initially when they had COVID to fully recover, and just tried to jump back into their lives and do everything that they were used to doing before, and that really set them back. I've treated very high level executives, leaders in our healthcare system, people who are very, very high functioning at baseline, who just jumped right back in to try to do the exercise that they normally do, work the way that they normally do all of the things that they normally do. And that really set back their recovery. So I do think there's something to be said for taking the time that you need after acute COVID to recover, before getting back into all of your usual activities and doing sort of a gradual return to activities. So I think that is important. And then it's also important to recognize that people will have symptoms without necessarily having objective findings, that we don't have the granularity in terms of the lab tests and other workup. And so most of the patients have largely subjective symptoms with not a lot of objective findings, although many of our patients have lots of abnormalities in labs and other things. So I don't know that I've helped clarify. I'm acknowledging that it's a very challenging problem.
Yes,
So, go ahead.
Yes, I agree with Dr. Friedli that no two people are the same and they should be treated differently. In terms of the return to work process, yes, we'd like to definitely consider the tolerance of the worker as well as their capacity and their physical limitations, as well as cognitive limitations. So it'll be individual basis, considering whether the worker is ready to return and how much work that they can take on and what type of modified duty or reduced hours are needed for this specific worker. But I think that there is overall guidance about like how to prevent disability from the occupational disease, such as being like too long time away from work make it hard for a worker to return to work, because it is hard to readjust ourselves to the work environment. So the guiding principle is that like the importance of the job accommodation at workplaces, as well as too much time away from work is not helpful for the return to work for our workers is one of the things that I would like to mention. Thank you.
So being a neurologist, I, of course, was very interested in the UK Biobank report and the involvement of the prefrontal cortex and the olfactory. And I'm wondering whether you have found it very helpful guiding principle-wise or whatever in terms of brain fog or any other mental issues to get more formal testing of smell or taste, and whether you find anything related to that helpful.
Yeah, so that's a great question. We're actually doing research right now at UW, looking at the connection between sensory loss, loss of smell, and cognitive function, and there is actually an association. So we are finding that people who have a loss of smell are more likely to have ongoing cognitive impairment, and so this is something that we're actively researching. So I do actually think that trying to objectively test for loss of smell could be helpful in helping to know what somebody's risk is, or that association. But we don't really know what to do with that information yet, and we haven't really established how to treat that. So I think it's still in the research phase. I don't know that I would necessarily go out and test everyone for loss of smell, but it's definitely something that we're thinking about. And if people are identifying that loss of smell is one of their major symptoms, then testing for it in the clinic using a smell kit can be helpful.
So can that just be done in typical offices with some kind of a protocol? You don't have to go to an ENT, which probably doesn't know how to do that anyway.
Yeah, there are smell kits that you can use, and protocols. You can do a sort of a modified version of this at home as well, but there are some standard kits that we use in our clinic to be able to identify loss of smell.
Thank you. That's really interesting stuff. So you mentioned we talked a lot. You talked a lot about POTS type things and blood pressure instability. Have you found it useful to use drugs like Florinef or other kinds of drugs that used to be used in like Shy-Drager syndrome, people that have orthostatic hypotension?
Yeah, in patients that have notable orthostatic tachycardia or instability of their blood pressure and high blood pressure, we have been using. We first start with non-medication strategies, so lots of fluids, salt, electrolytes, compression, recumbent exercise are all sort of the mainstays of treatment for that. But we are finding that people respond well to propranolol, to beta blockers if their blood pressure allowed for that, especially people who have more of the tachycardia. So that's usually where we start. But then there are a number of medications like Florinef and other sort of secondary medications that can be used for treatment. So we do follow a lot of the guidelines for typical POTS treatments, and those do seem to be effective in these patients with or without a formal diagnosis of POTS.
Ji Young, have you seen any of these kinds of treatments being applied to our workers?
Not some of them, yes, they were getting the propranolol for the heart rate issues, and yes, some of them for Florinef, I haven't seen when getting it, but lots of workers with post-COVID conditions, yes, have autonomic intolerance symptoms, and they have degree of varying symptoms that affect their daily lives. And as Dr. Friedrich mentioned, the AAPMNR multi-collaborative consensus guidance on common POTS conditions such as brain fog, fatigue, cardiovascular symptoms, and autonomic dysfunction have been tremendous resource and very helpful resources that's available on the website.
I found it very, very interesting. When Dr. Friedli and I think Dr. Nam also mentioned the issue of, patients seeking specialists for these sort of single organ complaints, wanting to know more about it, but maybe not being that helpful. We, of course, see this in other ways too in our regular business with low back pain, with, primary care docs getting spooked by certain patients with persistent pain, send them to a surgeon, and then they, maybe recommend surgery. So are you seeing the specialists that these patients have seen that then come to you? Are some of the specialists recommending things that you think should not be done?
Well, I think there's a few things happening. One is that many of the primary care physicians are either not familiar enough with long COVID and how to assess and manage it, or frankly don't have the time because it does take, these initial visits with patients oftentimes take 60 or more minutes to really delve into what's going on and sort it out. So patients who are seen by physicians and primary care physicians who aren't familiar with long COVID tend to get referrals to many different specialists. Oh, you have shortness of breath. Okay, let's send you to pulmonology. If you have chest tightness, let's send you to cardiology. You have brain fog, let's send you to neurology. And so those patients then are seen by those specialists, and most of the time, especially people who had mild to moderate COVID initially, they are getting workups done, and then they're negative, and the specialist sends them on their way and says, well, it's not a brain problem, it's not a lung problem, but the patient's still experiencing the symptoms, and so it's very frustrating for them. They don't get the answers that they need. And they don't understand it, and no one is taking the time to sort of piece all of these things together, and so they're confused. So then they start seeking out more and more things, and oftentimes they're looking on the internet, they're looking at online support groups, and that's when they start to go down the path of these experimental workups and treatments that sends them, I think, on the wrong path. So I think, one of the things that we're focusing on is really trying to train primary care physicians to be able to so that they have the confidence to be able to manage these symptoms, and to really explain to patients how all of these symptoms are, fit together, and how they're much more likely to be a systemic issue rather than an organ specific issue. The challenge, of course, is that there's such a range of impact of COVID. So certainly there are people who have had COVID pneumonia. If you've had COVID pneumonia and you're having ongoing shortness of breath or any changes in your oxygen levels, you need to see a pulmonologist, and need to get that testing. So there are definitely cases where there are cardiac issues and pulmonary issues and specific things that we're seeing. But for the most part, I think you can avoid a lot of those specialty visits if you have a physician who can put it all together in a way for a patient that makes sense to them, and then you can start chipping away at those symptoms in more of a holistic way. I think one of the biggest pieces of advice that I have taken away from working with the patient collaboratives that we've been working with, so many of the patient advocacy groups, was some advice from a patient saying, the patient who is seeking all of these different specialists, they're very confused. They want answers. They need to have that reassurance from all the different specialists. If you see them back frequently, you see them back and pre-schedule every month for 6 months a visit with that patient, you're going to cut down cut down those visits to specialists, because they're going to know that they can come and see you and that they can get their questions answered, and that they're going to have another visit with you coming up. And we've used that strategy, and it really does work. It helps to give patients the feeling that they have a home and they don't need to keep seeking out different specialists from all different systems to get their questions answered.
I absolutely
Go ahead, Ji-Young.
agree with you, Dr. Friedli. As you mentioned, the word matters, and over medicalization is not helpful, and it's actually harmful at this point. And the care fragmentation and the clinical uncertainty leading to more diagnosis testing, more referrals, and more duplicated care has been a big problem related to long COVID, and providing the needed reassurance to the patients have been tremendously helpful for people who had long COVID conditions. And I think that you mentioned this so well about like how the word matters for the patients. Thank you.
So this cautionary tale and specialty involvement maybe should also be a cautionary tale for how workers' comp insurers use IMEs in this situation. You know, somebody has 14 different task symptoms and they get sent to an IME, and one of them is a neurological IME, and they go, this patient's doesn't have any cognitive loss. And so I just think that we, as you know, in the workers' comp field, should also take a cautionary tale about the specialty use, and then extending that to, you know, how useful are IME, specialty IMEs in this case. And I wonder if either one of you have any thoughts on that.
Yeah, I mean, I would say that all of these symptoms are related. And so I think it would be really helpful to have IMEs done by someone who's very familiar with long COVID and can put all of those pieces together and look at it more holistically rather than, you know, looking at it specialty specific. It doesn't necessarily mean that it's not a neurologist. We have in our past collaborative, and many of the clinics around the country are led by, you know, in general physiatry, general and internal medicine. We work with family practice doctors, and then there are pulmonologists and neurologists. And so it doesn't, the specialty itself may not matter as much as someone who is confident in working with people with long COVID and have that sort of holistic experience.
Yes.
Gia, do you have any thoughts on the IME business?
Familiarity with the long COVID topics and the conditions are very important to evaluate the patients and our workers. And in terms of the IME and specialists, yes, visits, I think that discerning the quality of existing medical literature is very important, because there are so many disinformation, misinformation related to COVID infection as well as long COVID. And as more and more articles are coming out about long COVID, it would be very important to keep in mind that the evidence, the quality of the medical evidence is very important. Thank you.
We have about 7 minutes left. We have over 200 people on this webinar, and I'm going to encourage folks to put your questions into the Q&A function if you have additional questions. So one of the things that Ji Young, I know, has run into is, you know, various types of mental status screening tests. And for example, the mini mental state examination, which is probably worthless in general. And I wonder if you all could comment on whether there's any use for these kinds of screening tools.
Yeah, I would say in terms of the mini mental status, most of the screening tests for cognitive dysfunction in the clinic are not sensitive enough to get at what people are experiencing. We certainly screening for depression, anxiety, and mental health conditions is really important, and we definitely do that. But I think those other, you know, screening tools may be too insensitive. We are at UW working on a research project to look at comparing full neuropsychological batteries to an abbreviated, very short battery that could be used in clinical practice for long COVID. Because when we do formal neuropsychological testing, we are able to pick up a number of issues and be able to sort through what is likely related to an attentional deficit versus, you know, memory issues versus fatigue related cognitive impairment versus mental health related impacts. But those neuropsych testing is extensive and way more extensive than most patients need. Obviously there's a limited resource and they're very costly. So trying to come up with a very short battery is something that's high on our list of things to look at.
Are you seeming to see more types of gray matter versus white matter issues, like, perception issues might be more white matter, trouble with things around language might be more gray matter? Are you seeing any difference in these types of things? Like multiple sclerosis patients, for example, do not have classical cognitive problems, but they have severe cognitive problems, mostly from white matter involvement. And I'm wondering if you're seeing any pattern along those lines.
Yeah, it's a great question. I haven't thought about it quite in that way, so I'd have to give it a little bit more thought. The things that we're seeing in general with the cognitive dysfunction are, attentional deficits, so inability to multitask like people used to, so focus and attention issues, and we're seeing a lot of word finding and sort of higher level memory issues. So those are the kinds of things. So it's like, sounds like it's likely white matter, more white matter kinds of issues. We also, to note, a lot of my patients have described a concern with driving and longer distance driving in particular. And this may be relevant for return to work strategies as well. That when the amount of focus that you need when you're driving, in particularly longer distances, or when you're driving in high traffic and situations, or in inner city, that people are having sort of delayed response times, so reaction times, and the visual input and all of the things that they need to pay attention to is really cognitively demanding and fatiguing, and patients are scared to drive. So just something to consider when thinking about how cognitive issues may affect people's activities during the day.
Ji Young, do you have any thoughts on that?
Yes, so in terms of the Mcot or SLUMS tests, they are well-validated tests and good to detect the early cognitive impairment, and it is often used in geriatric population to detect like early signs of cognitive impairment or dementia. So like for our workers with post-COVID conditions, especially older workers with pre-existing concerns for cognitive impairment, I think that there is some utility of these types of screening tests, such as Mcot or SLUMS tests, as you're getting a baseline and getting the sense of the functions, cognitive function, as well as Dr. Friedli mentioned, PHQ-9 or GAD-7 measure questionnaire for mood symptoms have been very helpful to see how the severity of anxiety and depressive symptoms, as well as time goes, how those scores change, and like monitoring the mood symptoms can be quite helpful. Thank you.
Can I just add one quick additional comment that I think is important about the PHQ and the GAD-7. So one of the things that we have identified when we use the PHQ-2 or the screener that has the first two questions from the PHQ-9 and the first two questions from the GAD-7 as a screener that's commonly used in clinical practice, that oftentimes people will screen positive. They will. Sorry, I should say. When you use the GAD-7 and the PHQ-9 as the screener, oftentimes people will screen positive for depression and anxiety because they are answering the questions about their physical symptoms. But if you use, and that it may not be true depression or anxiety, but it's related to the physical symptoms that they're experiencing. When you use the PHQ-2, so the first two questions of the PHQ and the first two questions of the GAD-7, those are the symptoms that are more directly related to depression and anxiety, and might be a better initial screener for depression and anxiety. if you use the GAD-7 and the PHQ-9, you might get false positives from people who are having physical symptoms, but not necessarily the true depression and anxiety symptoms. So we actually in our clinic use the PHQ-2 and initially as the screener for depression.
Thank you. I'm going to squeeze in one last question here. We're actually at time, but short of having a wonderful elite team like you have at the U, to treat some of these patients, I really like the possibility of applying the Progressive Goal Attainment Program, PGAP, the kind of thing that Mick Sullivan developed in Ontario for injured workers with low back pain, as some kind of a combination of a bit of cognitive behavioral therapy and a bit of reactivation. Do you have any thoughts on that?
Yeah, I think something like that could work well. I think that the only caution is that if somebody, some of the patients that have the chronic fatigue with the post-exertional malaise, you have to be a little bit cautious about how you do the exercise. And so we have a very specific protocol that we use, more restorative exercise that is, starts with breathing exercises and then, very gradual increase in activity, but recognize that post-exertional malaise happens in many of our patients and happens the next day or 2 days after the exercise. And so you just have to be a little bit cautious in how you design the sort of activation protocol.
That's great advice. Shi-Young, do you have any other thoughts on that?
Yes, I think that the activity program, the PGAP program, has such a important role in our post-COVID condition workers, because when I was reading through the client workbook, I was surprised the overlap with current PCC guidelines, such as focusing on sleep hygiene, gradual advancement of activities, and the 4P strategy, energy conservation. So I think that it can, if it can be used in the right setting at the right timing, it can make big difference. Thank you.
Well, thank you both so much. This has been terrific. And if we're in the same room, we'd be giving you a big round of applause. So thank you so much for your amazing information and thoughts and wisdom. Thank you.
Thank you.
Yes, thank you all. Gary, though, before you guys go, did we, there's 2 questions in the Q&A, and I wanted to make sure that we address them. And I would also ask the folks that are in the panel that I will be moderating after the break to also take a look at them, because I think for the one regarding where do we go from here with the injured worker that's done a lot of treatment, I think the legal and adjudicative panel will probably address that question as well. But did we cover the question about the comorbidities?
I think there was quite a bit that Janet talked about in terms of comorbidities. The take-home message is that they're very common, and that people that have substantial comorbidities like diabetes or obesity are much more likely to get more severe past symptoms afterwards. I think that's my take-home message. So I think that they did answer the question on the comorbidities, but I think you cannot. It's very hard to sort them out in the way we usually like to sort them out in a workers' comp environment.
Thank you. Make sure that we're, completely addressing the questions that are posed. And do you have any thoughts on that second one about where do they go once they've done seen all the specialists, done all the testing, it's all negative. And like I said, we'll address it from a legal and adjudicative standpoint. But do you have any thoughts from the medical standpoint? There's been no change. Where do they go? And go ahead.
Yeah, well, yeah, I think what I heard is that most of the specialists don't know a damn thing. So I think what you really need is someone who's going to take a holistic view of the patient, taking all of these symptoms and under the theory that these things are probably somewhat related to each other, not individual organ problems, but some hyperimmune function or microclotting problem or whatever. I think you have to think about it in a more holistic way rather than this individual organ subspecialty way that we normally think about these things. That's my take-home message.
I think I heard the same. So, but I wanted to hear it from you all. So again, thank you all very much. This was a great panel discussion. We will now take a break. We'll take about a 10-minute break. Like I said, there's another panel coming up. So during this break, feel free to put in any questions in the Q&A for us to address during that panel discussion on legal and adjudicative aspects of long COVID. See you in 10 minutes. Dr. Franklin, you want to put yourself on mute?
Yes, thank you.
Mhm. Okay, everyone, welcome back. Give everyone a second to get back to their seats and get adjusted. Hopefully you did like I did and got a refill of your tea or your coffee. We are now going to move on to our panel discussion on legal and adjudicative aspects of long COVID. I will moderate this particular panel, and our panel members are going to be Mark Goodwin. Mark is a claims operations manager with the State Fund at the Department of Labor and Industries. Starla Tresnowski is Self-Insurance Policy Operations Manager here in the self-insurance section at the Department of Labor and Industries. Excuse me, and Deborah Hudjalexiou is the Legal Services Program Manager here at the Department of Labor and Industries. So you will have our legal advisor and claims operations manager from State Fund and self-insurance policy operations manager. And although many of you know that Lene Lean is our claims operations manager in self-insurance, Starla, however, handles a lot of the COVID claims and the adjudicators that handle the COVID claims, which is why Starla is on this panel instead of Lene. So good morning, everyone. Are you all there? All right, there we are. Okay, so we actually have a few questions. As we get going, you all should very much feel free to include in any questions that you may have that you've thought of since we started this morning, or based on what you've heard from the presenters so far. So we're going to start with a couple of questions, and a number of things have been discussed this morning about some of the difficulties. And it just is, there's a lot of difficulties and uncertainties from the medical aspect that obviously is going to lead to difficulties and uncertainties from the legal and adjudicative standpoint. So I'm going to start with a question with Deborah. As we know, we are an ACOS state in Washington, as opposed to other states in workers' comp that deal with significant contributing cause or major cause. So with all of this uncertainty, can you kind of give some guidance in regards to adjudicating with the uncertainty of COVID, particularly long COVID, but also taking into consideration that we are an ACOS state?
Thanks, Teresa, and thanks for having me. I think that COVID is actually a little easier to adjudicate than your garden variety occupational disease claims, because either there is a presumption that applies, in which case you aren't really concerned with whether it's a cause. It's presumed to, work is presumed to be a cause of the contraction. Obviously that's rebuttable, but I don't think it's as tricky to determine whether the work was a cause in the presumption cases. Now, if the presumption doesn't apply, and we're coming into that world soon. I mean, although the governor's mandate was over on October 31st, the president's is still in place, at least until sometime in March, I believe. And so our statute, our presumptive statutes still apply, the laws still apply. So that there are, of course, other cases that aren't covered by the presumption even now. Those are cases like, you know, we discussed one yesterday where I think the worker was an HVAC worker. And it's really difficult to show that work is a cause of the contraction of COVID when you're not in a healthcare facility, you're not, you know, in one of the employments covered by the presumption. So it's just back to adjudicating an occupational disease claim. Was it more probable than not? So even though it's just, you know, it just has to be a cause, it has to be more probable than not that it's a cause. So it's not just like, boom, you get it because, you know, the slightest percent of work caused your COVID. No, it has to be more probable than not. So you look at the natural and distinctive condition of employment? Was it naturally and proximately caused by employment? The distinctive conditions of employment. And in most cases, I think the answer is probably going to be no. The board has been rejecting some of the cases that we were allowing that weren't under the presumption. They did allow one claim, and that was a very specific circumstance where the worker, I believe, was employed by Tyson Foods, and the HVAC and the temperature in the room and the noise prompting people to have to speak very loudly, the board found to be distinctive conditions of employment such that it's more probable than not that the contraction of COVID was caused by the distinctive conditions. So we have that case law to look at. It's not even case law. It's a board decision that, I mean, it's a proposed decision in order. It has been, there was a petition for review, so we don't know what the outcome is going to be. Maybe the full board's just going to reject it outright. But that's the only case we have to go on right now. Some of the other cases, well, I don't think any of the other cases have been allowed by the board that we allowed. So the board is taking a very law-specific approach to their adjudication of these, which is appropriate. And I mean, just my personal opinion, I think we'll be seeing less COVID allowances with the ending of the presumption.
Okay, thank you, Deborah. Starla or Mark, I know you, this question was presented directly to Deborah, but if you wanted to add anything, feel free. Okay. So next question we have is for Starla. And in dealing with long COVID, so we heard earlier discussion, I believe it was Dr. Friedli who talked about, you know, when there's long COVID, there's usually 3 months of sustained symptoms, but also there can be kind of a gap, right? So in dealing with long COVID, how do we know if it is a reopening of an initial claim or a separate subsequent claim? So that is kind of combined also with the next question. So Starla, if you can address that, and then Mark, you know, tag in, you guys can tag in and out on, can someone have a claim for long COVID if they didn't have an original COVID claim? So
I think we need to look at the facts. What's it coming in for? If we get a reopening application and it's referring to an allowed claim for COVID, and now the symptoms are for long COVID, we need to process it like we would any other claim where we're getting a reopening. What is the causal relationship? Is it worsened? How the current symptoms fit into the previous diagnosis of COVID, getting the medical. I don't think it's a whole lot different than what we would see in other claims. I think there are times when we're going to see claims come in for long COVID where we didn't see a claim for COVID, and they have 2 years to file an occupational disease claim. So we may see ones where we go ahead and allow them when they don't have an allowed claim for COVID, but we were able to establish that 6 months ago they did have COVID, they just didn't file a claim for it. And it's still within that 2-year window for occupational disease claims. So we just need to establish, you know, at that time, was there a diagnosis for COVID? Were they tested? What are the facts surrounding the specific claims? Mark, do you have anything you want to add?
Yeah, I think you hit the nail on the head there. So there really isn't a claim for long COVID. There are claims for COVID, and so if I have a worker who had a prolonged hospitalization and then has developed symptoms, that's a fairly straightforward situation as far as the causation. But many people don't file claims because maybe they already have sick leave or they have some other benefit they're able to draw on. They're not out anything. They don't go and see the doctor. And then a few months later, now they have these symptoms and they're concerned about it, that it's long COVID. They file the claim. What we have to do is look back and say, is there a COVID infection? Can they show, with a positive test or some other medical that they had an infection at a specific period of time, and then evaluate, does it fall under one of the presumptions, or is it otherwise work-related COVID? So once we get to that point, we make a validity decision based on the original COVID infection. Then you've got the next step where you have to evaluate, is the current symptomology that they have related to that infection on a more probable than not basis. And that might be the more difficult part of all of this, but that's there aren't really claims simply for long COVID. It's a COVID claim because long COVID is a sequela condition. So.
Yeah. And also, when COVID first started happening and we started getting claims, we weren't seeing as many claims. There were a lot of federal programs that were paying benefits. There were a lot of state programs paying benefits. So a lot of folks didn't file industrial injury claims, even if they got diagnosed and were treated. A lot of them were only off for 5-6 days at the most. So a lot of them, went back to work and they didn't file an industrial injury claim because that's not something you're used to doing for this type of condition. And so I think we will definitely see ones as time goes along for long COVID where they didn't have an industrial injury claim.
Okay. And I would say there's no situation in which a reopening request would be a new claim unless there was a subsequent second infection, right, and that it too was work related. But if I have a recurrence of symptoms, I have a closed COVID claim, there hasn't been anything in the in-between time, then we would evaluate it like we would any other reopening. Yeah.
Yeah.
We also have a question. Would it be allowed if no original positive test is provided for long COVID, only a home test?
I don't believe we would.
Yeah, I agree. We're requiring some proof of infection in the form of a test that is independently verifiable. So in other words, not taking that home and only the worker can attest to it. I don't see why we would change anything if we were evaluating that same claim now down the road when it was filed later.
Yeah, I just want to put out one clarification. It can also be a diagnosis by a medical provider. And in the beginning, more than now, it was really hard for them to get the test. So sometimes doctors would treat them, they'd even do x-rays and stuff and diagnose COVID without a test for COVID. So there would be a medical diagnosis and an office visit, and that would be okay too.
Yeah.
Okay, thank you. So Deborah, Starla addressed it a little bit, but can you remind everyone of, the limitations on filing it, the time limits on filing an occupational disease claim, and how that will be the same or different with COVID?
Well, it's exactly the same, and it carries the same problem, which is a worker has 2 years from the time they're notified in writing by the provider that they can file a claim, and that I don't think I've ever seen that letter. So that does play into a long COVID claim where there wasn't an original claim filing. And, for whatever reason, the worker didn't know they could file a claim, or they didn't want to because they had other benefits. We're going to see cases where no claim was filed, and it's going to be difficult to apply the 2-year statute of limitations to these, because the worker can counter with, well, nobody told me, in writing. Nobody told me at all, much less in writing. And so it's going to be difficult to not accept that. However, we still are going to require the proof that we just discussed. It can't be their bare assertion. It can't be a home test that they have a photograph of, because who knows if it was their test. And so we would, if there is evidence that they had a positive test that's acceptable to the department, and then if they're trying to claim long COVID, as Mark said, they're going to have to show that relationship. But this is going to be tricky, because it seems like the long COVID symptoms are largely subjective, And we're gonna, if they're gonna come forward with evidence that they have long COVID related to the original contraction that was related to work, it's gonna be hard to say no. And so we need, I'm hoping that as the science develops into a greater understanding of the causes and, treatment, that will be better situated to help these workers. But right now, it's tough.
So we have a question that's following up on this home test situation. So how do you handle the filing of a claim within the 2-year time period? But data manifestation is during a time where home tests were allowed.
I wonder if Karen could clarify, what do you mean during a time when home tests were allowed? We have not been allowing claims with just a home test.
Okay, so while
Oh, your employer allows home tests. Well, that's a different standard. The department would not allow a claim with just a home test. I'm wondering if the employer is allowing home tests for the purpose of allowing you not to come into work.
so I'll let Starla address that from a self-insurance standpoint.
Yeah,
Okay.
I think self-insurance has probably struggled with it more because we do have employers that have medical facilities that test workers. We have also said that if an employer verifies a home test, if they are saying, yeah, that's fine, we're gonna accept this home test and wants the claim allowed, we're not gonna argue with the employer about it. And in the new WACs that we have right now in draft form, it kind of talks about the employer verifying the home tests. So that does happen. But if a worker just takes a home test and calls in and says, I'm not going to make it to work because I'm testing positive, and the employer should let them know that if you want to be off and we're going to allow you to have sick leave, that's one thing. If you want to file a claim, you're going to need a test verified by a pharmacy or verified at a testing facility, or you need to be seen by a medical provider. But if the employer says we're going to accept this and request the claim to be allowed, we're not going to argue, we're going to allow that claim, because a lot of our employers, that is what they have chosen to do.
And then Glenn has the statement in there, the department would also allow a claim based on quarantine regardless of home test.
Glenn works at a medical facility. So when we have healthcare folks, they're under one presumption that's different than the frontline presumption, in that they don't actually have to test positive for COVID. So they don't need a positive test. They can also have an allowed claim for quarantine. So if their employer is saying, we want you to stay home, you've been exposed, you need to take 3 tests before you come in, or you need to be off 5 days with no symptoms or whatever, they do have an allowable claim.
And so just as a reminder, Starla, can you just do a quick, there are these differences in the presumption?
Yes, there's the healthcare presumption. And I talked about this in another thing we have. There was some misunderstanding at the beginning that it was only for doctors and only for nurses. It really covers those who work at healthcare facilities in a pretty much broader range. So anyone that comes into patient contact or contact with others that have been exposed or may have been exposed, likely to be exposed, it's an allowable, they're under the presumption. So we have folks that take insurance information. Like the other day, we went into the ER for something unrelated, and you have someone that verifies your insurance is still accurate and gets your information. That person, if they have COVID, would be able to file a claim and fall under the presumption. You have the people that check you in as you go into the healthcare facilities and the ERs, and they are definitely covered under the presumption. And then we have a presumption for frontline workers, and it's really broad who is covered under that. It's teachers, it's meat packing plant manufacturers, and I won't get into it. It's a huge list, and it's covered under the RCW. But the presumptions are very similar. But for the healthcare one, the rebuttal is a higher standard, so it's a little harder to rebut claims for the healthcare workers, and they are also covered for quarantine. The frontline workers still have a, I think it's preponderance. I'd have to go back and look at my notes.
Yeah.
But they are only covered if they actually come down with COVID, not for quarantine. And both presumptions cover for the first 3 days after the date of manifestation. So time loss is payable for those first 3 days, regardless if they're off on the 14th consecutive day, which is very unlike anything else we do for claims. So those are a couple of the kind of weird little things.
And shout out to Kelly, our training supervisor in self-insurance, who just put into the Q&A that all of the info is online in the update training, which is under the self-insurance website under training. And Starla gave a really good presentation regarding COVID during update. There's also a question regarding what would the objective medical findings be for filing a COVID exposure claim to cover quarantine?
I mean, this is a situation where the coverage is triggered by the presumption. There really aren't any objective medical findings as far as quarantine. The grant of coverage says that anybody that works in a healthcare, who is an employee of a healthcare facility or an organization that provides medical or emergency services, who comes into contact with any individual who is or is likely to be exposed to COVID, that we cover under quarantine. So what, at least on the state fund side, what we've been doing is the employer does have to say, yes, this worker, we quarantined this worker. And that's basically all that's needed for the, the period if they don't contract the disease.
Bernie Pratt has put in a question, even with the healthcare presumption, don't your guidelines say that the worker needs to verify they contracted COVID or that they were directed to quarantine by a doctor or by the employer? And everyone is shaking their head saying yes.
Yes.
So we've talked about the fact that there's still a federal order out, and therefore the presumption in our law is still in effect. The federal order is set to expire sometime in March, so unless it's lifted before then, that is still in effect. But even after it's lifted, as we've talked about, there's a 2-year time period for filing a claim. And so there could still be some time that folks file a claim that would fall under the presumption. So what would an adjudicator look for in a presumption claim and deciding a presumption claim versus a non-presumption claim? So Deborah, you discussed this a little bit. Can you elaborate a little more, giving a little more guidance on, really what to look for when trying to decide how to adjudicate these claims?
I think we have to always go back to the statutory language and, excuse me, determine whether the presumption applies. And it's going to apply even to claims that are filed after the presumption has been declared over, or the emergency has been declared over. So when do they say in their application they were exposed or contracted COVID? Is it during that period? Is it not? And there's even going to be cases where they had COVID multiple times, some in and some out. And so it's really going to come down to what they're saying is when, what is the date of their test, or what is the date of their quarantine, and whether it's covered by the presumption. And as I said earlier, it's pretty easy to allow the claim under the presumption. It's not easy at all to allow it not under the presumption. And, I compare it to the SARS epidemic. We had claims filed for that, but even if people were a flight attendant, it's like, those aren't distinctive conditions. Anybody could contract it in or out of work. And so it's really going to come back to that kind of a practice where we're saying no more than we're saying yes. We'll have to closely examine the conditions of the employment to see, and maybe there'll be more case law developed as we move forward to guide us on distinctive conditions that are known to be causing COVID and those that are not. And what it looks like for the most part is not. That, you know, this is just something that can happen in everyday life, and it's going to be pretty difficult to show that you are more likely to contract it at work than in everyday life. I mean, I think tougher cases, closer cases will be in the medical profession for sure. I mean, they're going to have evidence that isn't found at a grocery store, right? Like close contact, known, you know, known connection. I'm trying to think of what factors could play in, like if it's
Well,
a
were there,
special part of the.
in some of the cases that you talked about at the board, where the board has denied some cases, but has also allowed one where they talking, I think there was some discussion about environment and the setting of the environment. Can either three of the three of you go into any of that, just kind of the factors that have been looked at in those cases?
Well, our flight attendant case was settled, so we didn't get a decision out of that. But I think the board was leaning toward not allowing that. And then with the Tyson Foods employee, again, there was like the cooler atmosphere, the need to shout, and something with the HVAC, how the air was circulated, caused the board to find those were distinctive conditions. And back to the medical example, I was trying to think if somebody is in a situation where they're in a room with a person and they have no, like I don't know, the person's quarantined, but you have to go in there. Maybe that would be more likely than not caused by the work. But I really do think that once the presumption ends, unless it applies retroactively, and it will to some cases, we're not going to see many COVID allowances. What do the rest of you think? Marcus, Darla?
No, I think that, I do think that's correct. I think we don't get, I mean, our percentage, at least on state fund side, that we get of non-presumptives now is quite small. And so once the presumption ends, I don't see us allowing a lot. I mean, we're going to be allowing a lot fewer claims, and I think there'll be fewer filed because there is no presumption.
Yeah, I think, you know, I still see circumstances where maybe medical providers, because before the presumptions, we would see cases where you have a nurse or a doctor that's treating someone that they did not realize had presumption. They came in for a heart attack or something, so they didn't have some of the protocol in place that they would have for someone they knew was contagious, and then come to find out. So that's one thing I can think of where it may boost them up.
Okay. So there's a question about current long COVID claim who had been off work and underwent numerous treatment, gets COVID again, and now wants all treatment for this new infection covered under the claim. Should this be covered? I would imagine there's got to be a question in there regarding relation to work on the new infection.
If they're off work, then and they get a new infection, I don't see how that could be work related. It's not like a back injury that you're off work for and then it gets exacerbated by, you know, some minor activity or something. I don't think that would be a coverable situation.
I agree.
Okay, I think we all agree. I think there has to be, the new infection has to somehow be related to work.
Yeah.
Wouldn't claims in industries such as healthcare still be allowed post presumption? You guys, Deborah, you wanna?
I don't think so. I mean, like I said, just like with SARS, it's not a distinctive condition of employment. It's something that we're all exposed to everywhere. So I don't see us allowing many
So I think
non-presumptive
they'll be
COVID
just back
claims.
to adjudicating like a regular occupational disease claim without the presumption, right? So,
Right. I
so
mean,
getting
it's like
over,
the flu.
right,
you
getting
know,
over that
it's
hurdle of,
exactly that.
yeah, so it's still the worker would have to still get over the hurdle of distinctive conditions of employment without a presumption. And we know how difficult that can be. So will we still see the claims being filed? Yes. Will there be a possibility of them being allowed? Yes. But will more of them be denied than allowed without a presumption? Probably yes. Can you close the prior COVID claim if there was an intervening new non-work related COVID claim?
What a great question.
That is a really good
Whoever
question.
asked that, hats off to you. That's a good one. Can you close the part? Okay, so I guess it would depend on whether the prior COVID claim was ready for closure. I mean, how do you separate the two?
I mean, it's just like if it was a back claim, right? I mean, if you had a back injury, you were treating for it, and you got into a car accident that was not related to work, and you got another
Which
back
we
injury.
see.
That's why I'm relating it, right? Because we do see that, right? And just like we struggle to separate them when it's a physical condition, I think the struggle is going to be the same kind of struggle with COVID, right?
The struggle is real.
I was going to say that. But yes, I think that is going to be the difficulty. I think a lot of what we're learning is the law is still the law. You know, COVID is, you still got to apply the law with regards to how we analyze claims. So that's interesting. So I'm going to get to that question where it says the answer on healthcare appears to be a position from the way claims were being allowed prior to presumption rules coming into play. I'm going to get to that because I have a question addressing that I think will address that a little bit. So, and that's actually, that goes to our next, a little bit to our next question. You know, we've had a lot of uncertainty, right? When COVID hit, no one really, we were in a pandemic and states of emergency, and a lot of uncertainty, a lot of not knowing what to do. And when we consider the spirit and purpose of the act, how we want to treat our fellow man, morality, do we err on, did we kind of err on the side of being wrong and giving too many benefits? Or should we have erred, or should we err on the side of being wrong and denying benefits? So Starla and Mark, I think that kind of goes to the question also about that seems to be a change of position to the way things were handled early on, right? So Starla, Mark, either one of you or Deborah.
Yeah, so it depends. It's probably the best answer. It really, should we err? Right now with non-COVID adjudication, we're always evaluating what the preponderance of medical evidence is, and we make our decisions based upon that. There are times in which, it's not clear and we give benefit to the injured worker at times. But I don't think there's going to be any difference in that. You're still going to have to weigh through what the actual circumstances of the claim are, what the medical says in the claim, try to obtain the best picture you can and make a preponderance decision. That's what I see happening going forward.
Starla or Deborah?
I agree with Mark. I mean, I think when we first started seeing claims for COVID, we didn't have the presumptions in place, and we were working based on the governor's mandate and really doing the best we could. I mean, there were limited tests, so we would hear, from medical providers, oh, we don't have tests available, but based on blah, 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 we think they have COVID. Also, a lot of things were shut down. I mean, schools weren't open, and a lot of people weren't going to work, and they weren't going to the grocery store. So it was way more likely that their exposure did happen at work. So the climate we were working with was completely different. And now, you know, we've seen a lot of claims. Unfortunately, we've seen a lot of claims.
Yeah.
And we've did our best to keep up with the presumptions and the laws and the way, you know, the court system is looking at them. And we are at this point, I think, treating them much, except for the ones under the presumptions, much like we do other occupational disease claims. And we've really, state fund, self-insurance, Deborah, me, Mark, and some other folks have met pretty consistently through this whole thing to make sure we were trying to keep on point together and adjudicate as closely and most similar as we can, considering the differences between state fund and self-insurance.
Okay. So Glenn has another question. Have you guys looked at that? Deborah, could you see that question?
Reading it now.
So I suspect the adjudicators will still lean on Corrado applying the increased risk for healthcare workers. That case is closer to presumption for healthcare workers and has been used to allow other diseases that are also community acquired, not just COVID. Will there be any co-review of Corrado and presumption to make sure it's not overused?
Glenn, what do you mean by co-review?
Glenn, I don't know if you heard the question. What do you mean by co-review? So while Glenn is typing his, we have another question. Injured workers off work for COVID residuals. New COVID exposure is not at work, but the contended new exposure is at the medical facility while going in for evaluation treatment under the claim. Ooh, would this talk about compensable consequences? Would this be a continuation of the current claim or a new COVID exposure claim? These are really good questions.
Well, yeah. Thanks, LaDawn. I'd like to talk to you about this after. No. I think this one seems more like the worker who is in a car accident coming home from physical therapy. So I think it may be covered under the claim.
So would you guys agree that maybe a part and parcel compensable consequences kind of?
Actually, I'm rethinking it because, well, they'd have to prove, first of all, they'd have to prove that they got it there.
Yeah.
God. But the thing is, if they had, sorry, I'm losing my voice. If they got the flu at the hospital while they were going for treatment, I don't think that would be covered under the claim.
Yeah, I
You
think
know what
it
I
would be
mean?
hard to prove.
But if they got, so let's draw this out further, right? So if they got the flu, not, but if they were in the hospital getting treatment and they got MRSA, would the MRSA be covered?
Probably.
Yes, probably.
Right. So if they're at the hospital getting treatment and they show they've gone nowhere else because, you know, they've been doing nothing else, they're off work, they're not going anywhere else. The only place they went to the hospital, and now they have new exposure to COVID. These are not easy questions. They're, you know, and
They're great questions though.
it is because, you know, facts matter, and these are things that the law is still sorting out too, I think, right? I think that.
And I would ask, do we have the ability to capture these questions for
We do.
later use? Because these are really good questions for training.
We do. So Glenn clarified that he just wants to make sure that the case is not suddenly made synonymous with presumption, and that maybe discussion be had that they are not. So basically he wants to know, are we training our people appropriately that once the presumption is gone, how should it be handled?
I believe that we will. Right now, we're still in the presumption, and, you know, people have been trained how to handle non-presumption cases. We do it all the time. I mean, besides PTSD and certain healthcare issues that are presumptive for first responders and you know, law enforcement and firefighters, most of our claims are non-presumptive. And we adjudicate them the same way now that we will when the presumption ends. And if, Glenn, you see that we're being influenced by this case, please feel free to bring it up, because I have not seen that we're training that at all.
Okay. So there has been some questions, and there's been some discussions, a lot of discussion earlier by our doctors about comorbidities and pre-existing conditions. And so we have a question previously submitted about if a comorbid condition is pre-existing and stable, for example, asthma, but is worsened by long COVID, does the claim now include the comorbid condition? If so, for how long? So Deborah, I'm gonna start with you on this aggravation of pre-existing but stable condition.
Yeah, I mean, basically you have to return them to baseline, right? And we try not to make any decisions until the claim is ready to close about whether the aggravation is temporary or permanent. In this case, if the worker had asthma but was not taking anything for it, medication or inhalers or anything like that, and because of COVID, they had to start doing that, then we would either, for how long? I mean, it would be until they no longer needed to use the medication or the inhaler. Otherwise, it would be a permanent aggravation if they couldn't get off of it at the time the claim was ready to close.
Starla or Mark?
I completely agree. I don't think it's much different than any other claim we would look at. We look at, if it aggravated it, at what point it went back to baseline, or if it's a permanent aggravation,
And yet, again, you're making your decision off the preponderance of the medical information that you have to work with, just like we would on any other, non-COVID claim.
Right. And I think, Dr. Friedli, I think, spoke to the difficulty of this, right? Because if I remember correctly, she said, COVID kind of lights up a lot of stuff, right? And sets everything, I think she said, on fire. So that's a good, legitimate question. And I think it is, I think that we have to realize that in some ways, the law is always going to be the same. And that's why I said, okay, well, what if it happened with the back, right? It's going to be the same. So the second part of that, which I think you guys may have answered, is what is a comorbid condition that has worsened? What if a comorbid condition that has worsened had not been treated in a long time and baseline is difficult to discern? At what point is the claim no longer responsible for the comorbid condition? So.
I mean, it's kind of the same answer, because if you have a condition that is not active, but it's lit up, you have to return them either to a not active condition or you accept it as a permanent aggravation. It is difficult, but you look to the medical.
And that's going to
opinions you have.
We have a statement in here, and I think that speaks to kind of the difficulty, and the medical panel, I think, added to this, saying, you need a holistic approach, and there's not a lot of, there's not a lot that we know, and there's not a lot of folks in the medical community that, are doing this type of treatment and work. And so, preponderance is a weight. The statement that Lene is given is not based on the number that you have 2 doctors and 1 person, and someone else has 1 doctor, right? It's about the weight that can be given to those opinions and what are they based on and the credibility of them. And so it's going to be difficult and I think it was Glenn that made some statements about the difficulties in getting doctors that are familiar with this treatment and willing to treat under workers' comp, right? And so that is difficult right now for us to have the resources to get the answers that we need. And we recognize that you all, particularly in the self-insurance community that have to adjudicate these claims, will run into those difficulties. Please, we still have a few more minutes on our panel. So if you have any other questions, feel free to add those in to the Q&A. So what, as you all, the three of you have been part of a group that has reviewed a lot of cases, or practically most of the COVID cases that needed review by a group over these last 2+ years now. And we know that based on what Dr. Freely said, that with long COVID, there's persistence of symptoms 3 months after initial COVID infection that aren't explained by other medical conditions. The symptoms can be new after recovery from acute COVID or persist from the initial illness, right? So I'm just took some snips of some of her presentation. And the symptoms may fluctuate or relapse over time. There's always this difficulty of determining when someone is at maximum medical improvement, right? So how does, and then of course, by the time you administratively get through, processing, and then now the next thing you know, there's this relapse, right? So can you guys give adjudicators any guidance on that process, determining maximum medical improvement, and when does that happen? Mark, I'll start.
And there's a medical opinion that says.
Yeah, I mean, that's about the answer that I was going to give as well. I mean, really, we're not doctors. We'll need a medical opinion. If we believe there's permanent impairment, we would either arrange a rating exam or get an IME for that purpose. I mean, we need a doctor to tell us that they're at maximum medical improvement, because I couldn't make the call myself.
Right.
So
and making sure that whoever's telling you that is the appropriate specialist, like, heart condition. Well, I saw one for a heart condition. So is it a cardiologist? Is it someone that's treating their heart condition, and making sure that you have the right specialist and ask the right questions.
And there was a previous question about injured worker has been off work 1 year, seen the cardio, pulmonary, psych, PT, had inhalers, negative EKG, PFT, TEE, the rest of the alphabet, and there's been no change. And where do they go from there? As an adjudicator, where do they go from there?
That's a tough one. I think the thing is you have to treat them somewhat like other claims. I mean, it may be complicated, but we deal with other complicated claims, and we ask questions like, what is the treatment plan? What are your next steps, medical provider? Because we, like Mark said, we're not the medical providers. And so we need to ask those questions. And if they need to see a consultation where they have seen multiple specialists, what are you diagnosing? What is the treatment plan? Just to me, go forward like you would another complicated claim.
I agree.
And maybe this is apropos of nothing relevant to this, but my favorite question for a medical provider is when you're trying to determine whether somebody has a condition is, doctor, for this condition to be present, what would you expect to see? And did you see that on exam? I think it really helps when you can let providers know what specifically we need so that they can give it to us, or it's not there, but you're making sure that they know, here's what we need from you.
So Glenn put in a statement, several of the OCMED providers have independently reviewed studies and tried different treatments in accordance with the outcomes of those studies. Has the department considered asking providers to help with best practice lines? It might be too late, but there could be some value in looking at that since resources are limited. So I think that's a question that we can definitely take back and maybe provide an answer. I don't know that we have a complete answer right now, Starla and Mark, do you agree with that? And we'll take that question back.
Yeah.
Yes.
So there was another interesting statement that Dr. Friedli made. She had a slide that talked about things that are most related to worse anxiety in long COVID or impact of long COVID on health, financial concerns, interpersonal conflict within the home or with members. And then she had in bold, long COVID is not caused by anxiety or depression, although anxiety and depression are risk factors for long COVID and can make recovery more difficult. Assessment and treatment is a critical part of holistic care. How do you deal with depression and anxiety as a condition, potentially a diagnosed condition, where it's a risk factor for long COVID and can make recovery more difficult? But we also have, case law that says, the natural stresses you don't get depression allowed on a claim. So but you also want to treat this in a holistic way and get the person better, right? So what should an adjudicator do in that setting? Do they look at aid to recovery, maybe treat it as aid to recovery, or are they stuck with accepting depression or anxiety?
I would look at previous treatments for anxiety and depression and where they were baseline prior, if you could get that baseline, and then talk to the medical provider and say, is this something that has got temporarily worsened? What do you think? And then maybe authorize it as an aid to recovery.
Mark or
I think
Deborah?
we treat
Yeah, and I
depression as
agree
an
with
aid to
the-
recovery.
Sorry.
I think we frequently treat depression as an aid to recovery because it's the best, best thing you can do. And I always say treat early and often. And if something is impeding them, especially something like depression, which can immediately mushroom into a pension, it's like, it's in the best interest of the worker and the insurer to take care of that as soon as it shows up. And I think that's good for workers anyway. It's like, we care about you. We want you to get better. It's been, shown that you have depression and we want to treat you, like, show them you care, and especially about something like that.
I agree with the person who put in the chat, behavioral health interventions. That's also an option we have that is below accepting, or evaluating a condition to be allowed on the claim. We want to get the worker the help they need and the support they need. But like any other non-COVID claim, I think the mental health aspect of it has to be handled similarly to what we would on an injury claim, for example, because we know that mental health plays a role, but there's a point at which you can provide something as a stopgap to help them cope with the situation they're in. And then there's a point at which there is a bona fide condition that now is present and related to the claim. So.
And I really like the comment, don't ignore it, or not to ignore it.
Yes.
Because the worst
Yeah.
claims I've seen is when adjudicators does ignore it. They ignore the mental health, the depression, and don't deal with it. And those can be horrible for the workers. They're horrible on a claim aspect. So don't ignore them.
And would your answer change if there was no prior mental health?
No.
Okay. All right. We have maybe 1 or 2 minutes left. Any other questions for our panel today? All right. Well, thank you guys for participating in our discussion today. We greatly appreciate the contributions you've made. I hope that those of you that are attending have received some good information. We are now going to take another 10-minute break. And after this 10-minute break, we will have a presentation on modified chronic opioid therapy pilot. So we'll see you guys back in 10 minutes. Hello, everyone. We are back. Our next presentation is on the topic of modified chronic opioid therapy, the Mcot pilot, and it will be followed by a Q&A session with the presenters. Our presenters today will be Dr. Jason Foldman. He's an associate medical director here at the Department of Labor and Industries. Jamie Mai is our pharmacy manager here at the Department of Labor and Industries. And then Liz Oldmer, registered nurse in ONC here at the Department of Labor and Industries.
Great. And then I can share the slides, Starla.
So you'd rather share your screen instead of having Susan?
Yeah, I don't. We don't want to impose. We don't want to impose. I got them ready to go.
All right, there you go.
Can
Yes, we
can
can
y'all see my
it.
screen?
We can.
All right. Thanks so much.
Great. Okay, I can get us started. It's our pleasure to be here today to provide you with information on a state fund pilot called the Modified Chronic Opioid Therapy, or Mcot. We have 3 speakers today. I will be providing background information while Jason will be discussing the component of Mcot, and then Liz will be highlighting the resources developed by the work group to support this work. Next slide, please. So as many of you are aware, the US is still in the midst of an opioid misuse and overdose crisis involving prescription opioids, heroin, and illicit synthetic opioid, mainly fentanyl. So some data for you, more than 500,000 people have died since 1999 of an opioid overdose. We have over 10 million people misuse opioid in the past year, and over 2 million had an opioid use disorder. Exposure to high-risk opioid prescribing after an injury is significantly, substantially associated with long-term disability among injured workers. Next. So through early recognition by Washington State, there has been many efforts to address the opioid epidemic, including guidelines and rules. Elle and I implemented our opioid guidelines and regulation in July of 2013. This set a standard for prescribing opioid for a work-related injury or occupational disease. And because chronic opioid use is associated with substantial risk of harm, our focus at the time was really to reduce unnecessary opioid prescription and prevent the inappropriate transition of chronic opioid therapy to injured worker. And as part of this implementation, State Fund instituted a prospective collaborative authorization process between our claim manager and our occupational nurse consultant. So our claim manager can authorize opioid during the subacute period upon request, while our ONC can authorize, review and authorize any chronic opioid request as examples. And then we created resources to support our staff as well as the providers, things such as a new authorization form, having pain management consultants to help with peer-to-peer outreach, and then also training and refresher courses for our CMs. We leverage technology to assist implementation. It includes, new sort of document type in Orion to hold the new authorization form, as well as reminder pop-up confirmation and priority messages on our CM work list. We also develop a single point of contact for all appeal and protests. Next. The 2013 guidelines and rules have had a substantial impact on workers, providers, and our system. As you can see, the guidelines and rules have reduced the number of injured workers transition to chronic opioid therapy. Our goal is really to keep this rate below 1.5 per 1,000 worker. Next. It's also clear that the guidelines and rule have had an impact on the number of workers on chronic opioid therapy. However, we still have around 4,600 workers on chronic opioid in 2019. So it's really time for us to turn our attention on chronic opioid use in our population. And we also needed to align our effort with external group and other agencies such as the BREE Collaborative and the U.S. Department of Health and Human Services. Next. So when we analyze this 4,600 injured worker on chronic opioid in 2019, we see that most of our workers are located in Region 1, 3, and 5, and that Jefferson, Clallam, Kitsap, and Pierce counties seem to have the highest number of injured workers on chronic opioid therapy. Next. So I'm going to turn the presentation over to my colleague, Dr. Jason Fodeman, to discuss the strategies that we have developed to support workers on chronic opioid therapy. Jason?
Yeah, thanks, Jamie. So that was a really nice review of where we've been and the terrific work that the department, Dr. Franklin, you obviously have done on this issue over the last 20 years as a real national leader on this important topic. And now I'm excited to transition to talk a little bit about where we're headed, which is the creation of the Mcot pilot, the modified chronic opioid therapy pilot, and gonna spend the rest of our time talking a little bit more about that. So, we've been hearing from some of our clinical stakeholders, particularly primary care providers, large healthcare systems, community health centers, that they're really struggling with patients on chronic opioid therapy and don't know what to do. These are patients that have been on opioids for many months, years, many years. And we've been hearing from our providers that they feel like they're getting pulled in competing directions. And then at the same time, these patients can be very time intensive, very resource intensive, with complex medical, complex psychosocial issues, some of the most complicated workers in our system. And we're also hearing from our providers that they feel like they don't have that time, they don't have that resource. And in many ways, we really kind of see this as the last frontier of the opioid epidemic. And we've heard this feedback, and we've heard these concerns, and Elle and I would like to help. And so to help, what we've done is we've created the Mcot pilot. And the objectives of the Mcot pilot are, we want to reduce harms, improve care for workers on chronic opioid therapy. We want to promote evidence-based treatment for chronic pain. We want to review claims on chronic opioid therapy to identify harms, barriers, gaps in care, or suboptimal treatment, and then offer available resource to address the identified issue. In Mcot, we're providing resources and education to help busy providers manage workers on chronic opioid therapy. And then we're also, have been partnering with our field nurses in this endeavor and, participating in addressing the opioid crisis. And ultimately, we want to ensure that workers on chronic opioid therapy receive safe and appropriate treatment that improves their health and avoids long-term disability, allowing for a quicker return to work and a quicker return to more productive, fulfilling lives. So the Mcot pilot has 3 components, which I'm gonna just briefly review right now. Component number 1 is an opioid review team. And this is comprised of members with various functional areas of expertise, including claims manager, field occupational nurse consultant, VRC, pharmacist, and physician. And this team has been staffing claims of workers on chronic opioid therapy for about 6 months now. We started doing this in about April of this year. And when we're looking at the claims, the ORT is identifying harms, barriers to recovery, and suboptimal treatment, and then determining, what resource do we have that can help to address that identified issue in a worker-centered way. And the opioid review team is also coming up with a plan to engage the AP, engage the prescriber, and potentially engage the worker to participate in those recommendations, as well as authorizing and coordinating services as needed. I would kind of describe the opioid review team as like the hub of the pilot. And then component number 2 of Mcot, that's our field nurses. And this pilot has been done in partnership with our field nurses, and they're really playing a very critical role in this pilot. And the field nurses, they do that heavy lift. They review the claim file to really try to understand the treatment history, gaps in care, potential barriers or harm, really trying to figure out what's happened since the worker was put on opioids. Did they get better? Did their pain get better? Did their function get better, which, would be great? Or, did, they merely just, just get more opioids? And, again, these are, very, dangerous, high-risk medicines. And, a lot of times, nobody knows because people just don't have the time to, review these very complicated claim files. So the field nurses do that. Then, they present the claim to the opioid review team. And based on recommendations from the ORT, the field nurse then engages the provider, engages the worker in clinical pathways that support safe and effective pain treatment. And then component number 3, that's provider education. And the team is monitoring and promoting existing educational opportunities that align with this work, such as regional pain conferences, and then also monitoring and identifying educational gaps and developing educational resources on these topics for providers to target those gaps as needed. So a work group of OMD, our field nurses, regional leadership, and other key stakeholders met regularly for over a year to develop the policy, the process to be able to do this work and to support our field nurses in doing this work. And together, the team, we refined criteria for identifying workers on chronic opioid therapy to review. So as Jamie mentioned, we have 4,500 workers on chronic opioid therapy. And, obviously it would be great if we could review all these claims, but, one, we have to be, mindful of resource constraints. And then two, we need to start somewhere. So we refined the criteria for which workers we were going to focus on. We developed a template, checklist to facilitate the claim review, to ensure appropriate focus, i.e., what we want to get captured gets captured, and then consistency amongst those various claim reviews. We've developed a list of available resources in the regions. We've developed policy and process to support this work. And then we've also identified the training needs of our field nurses to be able to do this work, and then developed and provided them the training and to be able to perform this work. And then concurrently, we've been working very closely with the Lean Transformation Office, the Office of Change Management, communications, to develop the communication to ensure successful implementation of the Mcot pilot. And this includes internal communication as well as external communication. For providers, we've presented to our medical advisory committees, IMAC and ICAC. For medical office staff, we've developed a flyer talking about the Mcot pilot to raise awareness. We've developed communication for the vocational community, who also participates in the opioid review team. And then we've also given presentations to other key external stakeholders like Achieve, our business and labor advisory group. And then we've done a tremendous amount of internal communication as well. So it's been a real pleasure to talk about this exciting work and the Mcot pilot today. And before I turn it over to Liz to talk a little bit more about our policy and process for the Mcot pilot, I do just want to take this opportunity to recognize and thank the great team that we have that has made all this possible, and really grateful for their hard work and expertise. And most importantly, we're really excited to be addressing this important issue in our system and helping our providers and helping our workers with this issue. And with that, I will turn it over to Liz.
And really quickly, there's a question in the chat. It says, can SIE tap into opioid review team?
So I actually was going to be addressing that. We have a process in self-insurance on how we coordinate with OMD, and we in self-insurance actually have a meeting scheduled at the end of this week, I believe on Thursday or Friday, with OMD. And so we will get back to you all on an answer on that question. But generally speaking, if you feel as though you have a question or a concern with your claim, you should be reaching out to self-insurance. And if we feel as though we need OMD review to help us resolve the issues or concerns, or as another set of eyes, so to speak, we have a process in which we refer things to OMD from self-insurance.
Thanks so much, Narissa. I appreciate that.
Well, now we'll move on to the Mcot process and resources. The Mcot work group began meeting last year and adopted criteria to identify workers on chronic opioid therapy. That would be the focus for this pilot. We agreed on the following criteria. The focus would be narrowed to workers who have been on chronic opioid therapy for 60 days or longer, and those claims currently open and open when the opioid prescription was filled by the worker. We further determined that we wanted to concentrate on workers who are not legally represented and those whose claims are a year or less in age from the date of injury. Additionally, we wanted our attention on workers who have a prescriber who belongs to our medical provider network and the ability to treat L&I patients. Furthermore, we limited this pilot to those workers with state fund claims. As you can see in the bar graph, we obtained data from the first quarter of this year. The orange and gray bars show how many workers were on chronic opioid therapy and how many prescribers by region. There were 365 providers across Washington state, and we have 277 injured workers on chronic opioid therapy. The Mcot pilot hopes to have a significant impact on the trajectory of these claims. Next slide. Now that you know who will be the focus of the Mcot pilot, let us discuss the process. As a work group, we discussed and planned how we envisioned this work to flow. The first step will be for research and data services to create a list of workers on chronic opioid therapy by region based on our conditions. Second, the Office of the Medical Director will validate and deliver the list to the field ONC in the appropriate region. Third, once received, the regional ONC will review the claim and complete the chronic opioid therapy checklist in about 10 to 14 days. Fourth, once the review is complete, OMD will schedule a staffing with the opioid review team, which will be comprised of the claims manager, regional ONC, unit ONC, vocational counselor if assigned, pharmacist, and associate medical director. In step 5, the opioid review team will then assess the worker's need by discussing the potential barriers, opioid-related harms, gaps in care, or concerns over the treatment that is not evidence-based. They will then determine the appropriate resources to address the issue and establish the best engagement strategy. In step 6, that's where the regional ONC will engage with the attending provider and prescriber using the group's identified strategy. Next, after engagement has occurred, the regional ONC will update the team on the outcome of the effort. And the final step is authorizing services. The CM, unit ONC, and regional ONC will authorize and coordinate services as needed. Next slide. The work group has developed tools to support and assist the regional ONCs in their Mcot pilot work. We developed a chronic opioid therapy review checklist. This is a tool to support the pilot's claim review process and to ensure the appropriate focus to what is important and the consistency among regional ONCs. It collects information on workers' treatment history, opioid use, risk factors, and relevant comorbid conditions. In addition, the checklist helps identify gaps in care, potential barriers, or harm. We will use this tool to help facilitate discussion at ORT meetings. We also created an introductory letter to providers. These providers have workers who are on chronic opioids and have been identified as possible participants in the pilot. The letter informs the providers of the Mcot pilot and introduces them to the respective regional ONC. It also describes Mcot as a resource for busy providers and explains how we can partner to improve the treatment of chronic pain for an injured worker. The strategic purpose of this letter is to facilitate and enhance regional ONC outreach. Next slide. These tools are also designed to provide workers with evidence-based, worker-centered treatment for chronic pain that will improve chronic pain, or excuse me, improve pain control, improve function, and prevent disability. In an effort to expand access to alternative therapies and make them readily available, we developed a non-opioid alternative resource list for providers. This tool includes a list of evidence-based, non-opioid pharmacologic and non-pharmacologic alternatives. It also contains information and resource for substance use disorders. This is an easy-to-use handout with information on the department's coverage, and it will help regional ONCs in their engagement with providers. This will be available on the pilot's website. Finally, we created an extensive list of regional resources that ONCs can utilize to help providers and workers identify non-opioid treatments in their region. We hope this will enhance access to evidence-based non-opioid alternatives and improve the treatment of chronic non-cancer pain. This living document will be updated as needed. We hope this additional support for injured workers and providers will reduce the risk of harm from opioid use. Additionally, we hope that the pilot will support claims managers managing these complex claims while potentially decreasing overall long-term claims and workloads in our system. Now I'll go ahead and turn this over to Dr. Jamie Mai.
Great, thank you, Liz. We implemented, as Jason mentioned earlier, the pilot in April of this year when the ORT began staffing claims of worker on chronic opioid therapy. And although our prioritization criteria that Liz went through focused on newer claims, what we're seeing is that these claims have been fairly medically complex with a lot or multiple comorbidities. The University of Washington will be evaluating the impact of this pilot. They are currently working on a survey for providers whom our regional ONC have engaged and offered appropriate resources to address the identified issues and hopefully participate in the plan. Next slide. That concludes our presentation, and we have some time for questions. If there's any.
If there are any questions, just like with the previous presentations, please type them in the Q&A. Liz, you have your hand up? Was that an accident? Okay. I'm not seeing any questions. So thank you all very much for all of that. And I'm sure we all look forward to see how what the future holds regarding this pilot and what additional things we learn.
Right, thank you.
And thanks so much for the opportunity to be here today. We really appreciate it.
Thank you. Now we are on to our final presentation. Our final presentation topic today is utilization review outcomes. Our presenters today are Shauna Mondo, Utilization Review Manager here at the Department of Labor and Industries, and Shari Fowler-Korn, Director at Washington Government Services. Again, I apologize if I mispronounced anyone's names. Are you both on?
Yes. Yes, I'm here. My camera is broken, but I'm here and I'm sharing the screen. Can you see the presentation?
We can.
Great.
Thank you.
Okay, Shauna.
Thanks, Sherry. Hi, everyone. Thanks for having us today. My name is Shauna Mundell, and I'm the Utilization Review Program Manager. And we'll just be doing a brief overview on some utilization review outcomes. I'll mostly be doing an introduction, and then Sherry, who works at Comagin and contracts with the LNI, will be proceeding with the rest of the data. Next slide, please. Just a brief overview on what our relationship is with Comagin. So the Utilization Review Program at the department supports the agency's mission to provide evidence-based care for injured workers. We use the evidence-based treatment guidelines, which I'm sure most of you have heard of, the medical treatment guidelines, which we refer to. We also, if there are not medical treatment guidelines, we do use Interqual and refer to other entities. The department contracts with Comagin to perform reviews and make recommendations. Comagin health reviews are required for all inpatient hospitalizations, with the exception of chemical dependency and subacute stays, selected outpatient surgical procedures, physical medicine, advanced imaging studies, and spinal injections. Just to give a little bit of an idea of the volume of reviews that we do, it's usually between 55,000 and 60,000 reviews per year. And up on the screen here, we have 2017 through 2022, just through April. So we can have some updated data. Then there was a slight drop, as you can see, and is to be expected in 2020 due to COVID. But we have really come back up to the standard amount of reviews and are on track for that between 55 and 60,000 reviews per year. A little bit of background on timeliness and what the expectations are through the contract, and also Comagin, who follows URAC. For prior authorization or pre-service reviews, there are 15 days from the notification date. Typically, it happens within 5 days, but 15 days from the notification date for a response. If additional information is required, additional 15 days from the date that the additional information is received. Typically, that does happen sooner, but it's helpful to understand what those timeframes look like. For inpatient stays, and that's continued stay specific to ER admits and unplanned admissions, 24 hours from the notification date. And if there's a need for additional information, it's 3 days from the date that additional information is received. And finally, for retrospective reviews, it's 30 days from the notification date, which makes sense because, of course, this is a service that has already happened. And if additional information is needed, it's 45 days from that date of additional information. And with that, Shari Fowler-Korn, who is the contract manager on the Comagin side, will proceed with some more information.
Thanks, Shauna. And thanks for having us today. I think I presented to this group maybe seems like a long time ago. I'm going to date myself. I've been at this 11 years. I think it was 5 or 6 years ago at Swedish. And we collect a lot of different data. I want to just talk a little bit first about what we do. And the treatment guidelines that we use are LNI's medical treatment guidelines. So they're developed by the IMAC committee and subcommittee. We do participate in that mainly which is super helpful because we're able to understand the intent of the guideline, hear the discussion, have some input in terms of the way in which things are done in the utilization review world. And essentially the way things work at CoMagine Health, if a criteria is met, so if the guideline records that meet the guidelines, the nurse can make a recommendation to approve a service. We are not doing a medical necessity review, and I think that's an important distinction. What we do is review to determine if the criteria are met. So if the criteria are not met, we're not saying that a service is not medically necessary. We're saying it does not meet the department's guidelines. We do a tremendous amount of provider education through, we have a trainer on our team who trains provider office staff in addition to internal staff. Our staff are on the phones, and then we have physician reviewers on staff 8 to 5 every day. We have 4 full-time orthopedic surgeons who are available to speak with providers when there's been a denial, when there's a question about guidelines, and they do a tremendous amount of education about the process and the reason that L&I guidelines are the way they are when providers have had denials. The newest guideline was introduced in October of 2021. I can't believe it's been a year already, the lumbar surgery guideline, and it was a comprehensive overwrite of a guideline that's been in place, I believe, since like 2007. Initially, there was an HTA criteria, gosh, a long time ago. 2007 was the first one. It was updated in 2015. And this guideline took what was a very simple criteria and put every single lumbar surgery into one guideline. It was over 2 years from the inception of the subcommittee that developed the guideline to the actual guideline being presented to IMAC and voted on and started. It's clearly defines the requirements for each type of lumbar surgery. And the impact of the guideline, obviously the denial rate has gone up. That is not the intent. The intent of the guideline is to ensure that the surgeries that are being recommended for approval are appropriate based on the reason for the surgery. And this particular guideline has been fraught with a few stumbling blocks. The providers are very slow to respond to a few things. One is the requirement for nicotine abstinence documentation. The other is radiology reports. If the only imaging that's going to say you need a fusion is being read by the treating surgeon, they want there to be another radiology read that confirms the findings. And then the imaging criteria sets need to be with contrast, and they need to be more recent than within the last 6 months for most surgeries. And a lot of providers are pushing back a little bit on some of those things. But in general, over the last year, there's been slow adoption of some pieces of the guideline. We've worked tremendously hard with the department, and we think it's a really good guideline. It's just complicated. Injured workers don't do well as a whole with back surgery, so we want to make absolutely certain they need the surgery. We collect a lot of data for L&I, and I want to make sure to be clear, this is data on reviews. So it is not data on surgeries that actually happened, but just on requests for surgery, because we don't make the final determination. L&I makes the determination. We get a request and we say we either recommend approval or we recommend denial. And then it goes over to the claims manager, and the claims managers, the ONCs, the OMDs at L&I make the final determination about whether or not they're going to authorize and pay for the surgery. And as you can see, this data goes back to 2014. We changed systems in 2015, but there's been a significant drop in fusion requests from 2014 to now. It's almost 50%. And we can't really explain why, other than we do see providers, we'll see chart notes that say, you know, L&I won't cover this fusion, so we're just going to ask for a decompression. So we do think there has been some change in the practice of the providers. But there are definitely fewer requests. We're on track this year to have about the same number as last year, about 300 a year, but that's down from almost 600 in 2014. The denial rate went up considerably in 2014, 2015, and then last year it went way up. You know, we're up to about 50% initially for the end of last year. We're right about 40% right now, and there are 2 main reasons for denial of a lumbar fusion. The first one is there's no imaging findings, there's no findings on exam to correlate with the findings on imaging. And the second one is the no negative cotinine test, that patients are smokers and they have not been able to, either haven't been asked to quit smoking or they've not been able to provide the negative test results. Laminectomies also changed during this period of time. They're included in this guideline, and there was an HTA decision about covered with conditions for laminectomy in 2018. There's also been a huge drop off in laminectomy requests, I think also for very same reasons, that providers are only asking much less often. We don't see nearly the number of requests we used to see. I'm going to stop for a second. Liz Ottmer, do you have your hand up, or is it up from before? I can see it, but I can't hear anything. Okay, there we go. I'll go on. So again, the denial rate for laminectomies has been about 20% for the last several years. There are a few partial requests. Typically these get denied again because the patient has something on imaging, but they don't have any findings on exam. So there's nothing that correlates. They have to have 2 findings on exam, and most of the time they either have just one, like a sensory change, or they have no findings, they just have radicular pain. And it doesn't mean that they don't ultimately ever get a surgery. There are times when someone's got the same radicular pain for years and years, and over time, and we end up sending it to a spine surgeon. They do make some exceptions, but for the most part, absent findings on exam, there will be a denial for surgery on the spine. So the next big guideline that was introduced, the most recent one before lumbar surgery, was ankle and foot surgery. And this was a huge overwrite. Prior to this guideline, we only reviewed about 4 or 5 surgeries for foot and ankle surgery. And for the most part, they were inpatient. So at that time, back in 2017, 2016, a total ankle arthroplasty was always done as inpatient, and we always review inpatient services. It clearly defined the criteria for each surgery. Most of these patients, very rarely get requests for one procedure. It's almost always 2, 3, and 4 different procedures on the foot and ankle. The subcommittee had a tremendously broad group of providers that was podiatry, orthopedic surgeons whose practice focused on foot and ankle surgery, physical medicine and rehab, and pain management. And the department really developed a solid guideline here. The challenge for us has been that the foot and ankle surgery community has not been used to having anything go through the UR process. There were some things that required claims manager authorization, but for the most part, they just did the surgeries as they saw fit, and the guideline has been a huge change. Denial rate is upwards of 40%. It's usually partially denied, again, because of the multiple procedures. There's been a couple of things that have been particularly difficult. Lateral ligament stabilizations are very common, and people sprain their ankle all the time, and a lot of people have just sort of congenitally weak ankles. Can take up to a year for a complex ankle sprain to heal, and a lot of doctors want to take the patients right to surgery, which isn't always in their best interest. There's required to be some difference between the two ankles on X-ray, and there need to be objective findings. You can't just do surgery because someone has a finding on MRI. So the guideline, again, in this period of time in 2016 to here, we were really only reviewing inpatient stays. Then it just, in October of 17, when this guideline was introduced, all of a sudden the volume went way up, obviously, and the denial rate, partial approvals are still right around here, but the denial rate has stayed fairly high. And the physician review rate is really high. And I think that's an important thing to point out. 80 to 90% of these requests have some level of physician involvement. Either the nurse has to call and talk to one of our docs, or the whole case has to be reviewed by a physician. A lot of these are repeat surgeries. So they've had one, now they're having another, they've had hardware removal, now they've got arthritis and they need some sort of type of a fusion. So a lot of these patients have had 2, 3, and 4 surgeries, and anything beyond 2 surgeries automatically gets a physician review just to be absolutely certain that the worker really does need the surgery. And the denial rate has stayed right around 15 to 20% since we started. And then prior to that guideline, the knee surgery guideline was introduced in 2016, August of 2016. And I apologize, the slide deck that I sent had the copy paste error. So I will send the updated slide over today that has this one in it. But this took a guideline that was about 3 pages and made it into, again, a much more comprehensive guideline which covers initial surgeries and a lot of repeat surgeries. There are a tremendous number of injured workers having repeat meniscectomies without a new injury. And so the guideline addressed that. It also incorporated the work around whether or not someone who has a degenerative knee and no mechanical symptoms should be having a meniscectomy surgery. And the guideline that the LNI has adopted is absolutely in line with the national guidelines and the American Academy of Orthopedic Surgeons, all who say you don't do meniscectomy in a degenerative knee. The guideline has had a substantial increase in denial. Prior to this, there was about a 3 to 5% denial rate for knee surgeries. It has been 20% since the time the guideline changed, very slow adoption. And I think the challenges are that, the workers have a torn meniscus, they don't want to go back to work, they don't meet the guideline for surgery. And the real troubling patients are those who fall into what our doctors call the donut hole. They don't have mechanical symptoms and they have degenerative disease, so they don't meet for a meniscectomy, but they don't need a total knee replacement. So there's a tremendous amount of orthopedic surgery consultation that happens on these cases. We feel extremely fortunate to have the orthopedic surgeons to look at these. And then there's the state HTA criteria that does not allow for arthroscopic treatment of degenerative disease. So they can't just go in and debride and clean up a degenerative knee, because the literature shows that that just makes it degenerate faster and it's not the right treatment. So the knee surgeries prior to 2016, you can see the red, had a very few denials. And then the guideline went into place and the denial rate went up, and it has stayed up pretty much right about, you'll see on the next slide, about 20%. The request volume has not dropped off much. It did drop off in 2020, which we expected because of COVID, but the overall, unlike the other surgeries where we've seen the guidelines result in fewer requests for surgery, we have not seen that with the knee surgery guideline. And then this is all surgery denial rates. So as you can see, 6 to 10%, and now we're up in the 20% range, and we stay up in this range. Again, for all the reasons I've already cited. And then this is just meniscectomies. And the reason I bring this slide up is this is the vast majority of requests come in with at least a meniscectomy. And you can see again that the denial rate's high, the total number of requests is high. And you'll see like 1,143 requests for 1,113 workers. They'll just keep asking. We'll get new imaging, we get new exam findings, and we just get requests over and over for the same surgery. And then the meniscectomy denial rate is right around 14 to 20%. And then there have been a couple of additional guidelines that have been updated in the last few years. The cervical spine guideline in 2014, again, a major rewrite to include all of the criteria, including artificial discs, multi-level surgeries, and they really the guideline has guidelines for a single level, a 2-level, and then a multiple level procedure, guidelines for repeat surgeries for artificial disc. And it really was the first guideline that Ellen and I had published that specifically requires proof of abstinence from nicotine. And this one, providers actually do submit their requests with the cotinine tests finally 7, 8 years later. It's only if the patient's been known to be a smoker. But we have had, this one took a while again to adopt, but the guideline, the providers do actually now send us what we need. It just took a long time. And then the shoulder surgery guideline was the first guideline committee that I participated in, started in 2012, and it got published in 2013, updated in 2018. And this one continues to be, again, a solid guideline. We still see 2 procedures on this particular criteria are denied with regularity. One is the distal clavicle excision, and it's because the guideline requires 3 things. There has to be, most people over the age of 50, the literature will say have arthritis in their distal clavicle or in their AC joint. There have been studies on postmortem, people in their 60s, almost everyone has it, but most of those people don't have complaints of shoulder pain in their medical records. So you have to prove that it's a pain generator by doing a diagnostic injection. And then there has to be a radiologist read that says the patient has at least moderate to severe AC joint disease. It's not a benign surgery. It's not something you should do just because you happen to be in there. And that one gets denied significantly. We have some providers who request it every single time. And that behavior has not changed. It has changed with other providers. The other one is the biceps tenodesis. That particular procedure is requested with about 60% of the surgery requests with no pathology on MRI and no findings on exam to explain why they want to just go in and either cut it loose or move it, cut it and move it somewhere else. So those get denied. We have a tremendous number of partial approval, partial denials for surgery. And that particular surgery, a lot of providers have taken to not requesting it preoperatively and then describing what they find intraoperatively and submitting it as a retrospective request. And so we're seeing more of that being asked for retrospectively than prospectively. This guideline also looks at multiple rotator cuff repairs in the absence of new injury. And I didn't realize how many repeat surgeries injured workers have until we really started looking at this. And there are quite a number. And so we do look differently at a repeat rotator cuff repair, and those usually have to have a physician review just to be absolutely certain. If it failed the first time, you want to make sure doing it again may not be the right thing to do. In 2018, the department added the superior capsular reconstruction criteria. And right now we're seeing trends where there's a new device it's called the in-space subacromial balloon. And we have several providers in the South Sound who want to start using that. FDA has approved it, but there's absolutely no literature yet to show whether it has good long-term outcomes. And so it's currently being denied. And our role will be to let the department know as we start to see more of those requests, whether they may or may not need to develop a guideline. And with that, I will answer questions. Let's see. So the first question from the anonymous attendee says, on a distal clavicle excision, are most of those retros, as seems provider doesn't specifically ask up front? That should not be a retrospective request. You actually have to go into that part of the shoulder on purpose. It's not an incidental finding during surgery. And so in order to get it approved retrospectively, it would have to have met the prospective guidelines. So we would go back and look to say, did they have the findings on imaging? Had they had a previous injection, and did they have pain on exam? I believe the guidelines are on the website and are used by the self-insured payers, to the best of my knowledge. I know they're on the website. And Jane, I see your question about data correlating with fewer requests for surgery and a decrease in disability. And I don't know the answer to that question, because again, I don't know whether some of these denied surgeries get approved by the department, either through the board or the claims manager may authorize them. And I don't know the answer to that question. Shauna, do you know?
I don't have an immediate answer. I actually am not seeing the question, but I can definitely follow up after also.
Yeah, the question is about, is there data correlating fewer requests for surgery with a decrease in disability, like increasing injured workers returning to gainful employment?
Yeah, it's a great question. I think I'd need to follow up to give a more thorough answer, but we'll definitely take that back and look into it.
The other kind of interesting thing that I've learned is that just because a surgery gets recommended for approval on our side doesn't mean it ever happens. Not because the department doesn't authorize it, it's just a lot of the patients, for whatever reason, never get to surgery. And we'll get another request 2 years later for essentially the same surgery. They just never had it. And I don't really know what happens there. But this is definitely a complicated business with a lot of moving parts. Any other questions? Nope. Well, thank you very much. I appreciate your time.
All right, thank you. We very much appreciate you all. And
it looks like, sorry to interrupt you, a couple of questions popped in. There is not a guideline for a split tendon pectoralis transfer. I happen to know that because we have to send those to our shoulder surgeons. There is not a guideline that covers that. And I see the comment from the second person, and we deny the Mumford on the retrospectively if it did not meet the prospective criteria. I'm not sure what the claims manager does with it, but we don't recommend approval.
Okay, any other questions? Okay, thank you again. We all I really very much appreciate all of this information that you've given us today, Shauna and Sherry. We are towards the end of our colloquium, and we want to take a few minutes to say thank you to one of our Self-Insurance Colloquium Planning Committee members for his participation over the past 5 years. Lloyd Brooks has been the Professional Development and Member Services Director of the Washington Self-Insurers Association since March 2018. And he has participated in our Colloquium Planning Committee since that time. A couple other things, and then I know there are some folks that want to kind of give a shout out and send some love to Lloyd as this will be his last colloquium, at least in his current role. I'm sure that we will see Lloyd in other fabulous things that he will do in the future, and we all look forward to working with him. He has, I've been given some information, so correct me where I go wrong, Lloyd. Over 30 years of insurance industry experience, including employer representation before the board. He holds a Washington Workers' Compensation Professional Designation since 2004. He has had 2 terms on the Industrial Insurance University Board of Regents for the Washington Self-Insurers Association. And he, in 2008, was appointed to the Washington State Department of Labor and Industries Business and Labor IME Committee, which he currently still serves on. And he has been on he was appointed to a 5-year term in 2009 on the Washington State Department of Labor and Industries Retro Advisory Committee. He's done a lot of other things as well: leadership and mentoring, and complex claim analysis, public speaking, instigator for positive perspectives, professional training in the areas of Washington Workers' Comp, adjudicator certification, workers' comp culture, experience rating, and a whole bunch of other things that we'd be here another hour talking about Lloyd. So I will stop there and allow some folks that I know want to, like I said, say some things to Lloyd. So I will start with Chris.
Well, good afternoon, and thank you for inviting me into this brief little shout out to our dear friend Lloyd, who, as I think most in the community know, is transitioning out of the WSIA staff at the end of the year, but staying in the community and in the industry by pursuing some new adventures that maybe he will speak to, if not in this venue, and certainly in others. But really appreciate the opportunity to come on and just underscore some of the things that Naresa was just saying. It's been really my privilege for the last 4.5 years or so to be Lloyd's boss, although Lloyd requires very little bossing around. I've probably learned more from him in that time than he's learned from me. But just really excited about the next chapter in Lloyd's work. Want to thank you, Lloyd, for being WSIA's delegate to the Colloquium Planning Committee and helping bring these events to the now virtual stage, helping them keep going during the pandemic. It's been an important piece of work, but not only that, but all of the other different volunteer and stakeholder engagements that you've had on behalf of WSIA and the self-insured community these last several years. So we know it will continue in a different form, and we very much look forward to that. But Lloyd, it's my privilege to offer some thanks in this forum for the record of work that you've compiled here and elsewhere. So thank you.
Wow, thanks, Chris.
And Gary?
Yeah, I'd also like to thank Lloyd for your great partnership and collaboration on all the stuff that we've done together in the last 4 or 5 years. And I thought Lloyd was gone, but he's already asked me to do the next thing in his new life. So I look forward to working more with the community, because I really think that what we're all trying to do, which is to prevent disability and help workers heal and return to work and deliver evidence-based care so workers aren't harmed, we all want the same thing. Doesn't matter whether you're state fund or self-insurance. To me, it's the same. We're really the same thing. So thank you, Lloyd. Thank you for all your contributions, and I look forward to working with you ongoing.
Not quite yet, Lloyd. Don't go away just yet. I know Karen wants to say something as well.
Yeah, just briefly, I'll echo what everyone else has already said, but in particular, Lloyd, I've really appreciated the work you've done with us over the past couple of years, transitioning to a virtual platform here. It never ceases to amaze me that you've always got one idea or another, or we've tried this or done that, and it's really helped us mature our ability to present these virtual webinars as well. So I look forward to additional opportunities to work with you in the future, and really appreciate your passion for workers' compensation.
Wow. Well, thank you. This is very, very appreciated, unexpected, and I'm, as a rare occasion, few of words. Thank you. Thank you.
Well, we thank you. And as everyone has said, we definitely look forward to the many ways that we will continue to be able to work with you in improving and continuing our self-insurance community. With that, Lisa, are you with us? Lisa Vivian? Uh-oh.
I am here.
Hello.
Hello.
So Lisa and I are going to close out our colloquium today. Lisa Vivian, for those that don't know, is the WSIA board president. Is that correct, Lisa?
I am.
Want to make sure I'm listing the right things. So Lisa, you want to start off with any closing remarks, and then I will wrap us up afterwards.
Sure, thanks, Narisa. I just want to thank the Office of the Medical Director, Dr. Franklin, and his team for continuing to guide the colloquium. I can remember the very first one that was put together, and it kind of brings me back to the presentation done by Dr. Mai. And I think it was opioids was the topic of the time there, and with Dr. Franklin and his team being leaders in that field and pioneers, the science was way over my head at that time, and as kind of correlates to the science of today's topic, mostly on long COVID. It's way over my head again, and its relationship to workers' comp, and time will tell us, how it works and goes with our claims. But it just again reiterates to me, as a claims managers, we're going to have to become very skilled in how we lead the workers that we handle the claims for, in this learning how to get them on this path of recovery that Dr. Friedli referred to, and to help educate our friends at the Washington State Association for Justice about that this is a path for recovery and not a path to disablement. And I'm really hoping that the Department of Labor and Industries can help in this messaging as we help our workers recover from long COVID. I also was encouraged with Dr. Nam's presentation and the return to work aspect of that, and the leadership of the department in their return to work goals that Director Sachs has always had as a goal in his mind. That it reminds me that early intervention of vocational resources in these claims is going to be just as important as it is today on injuries, of trying to figure out how we incorporate those things, either through early encouragement, and just all the different tools that we have available to us to coach these people to getting back to work, and how important that is in their recovery. Another takeaway for me today was getting nurse case managers that work on our claims to become experts in helping these people recover, and why we have many nurse case managers that help us. It's going to require people that have special skills and knowledge about these types of claims, and really helping workers get from their attending physicians that don't know how to treat these symptoms and stuff, to avoid getting people down the wrong path, and getting them to providers that do know how to treat these type of symptoms. Because I think, it's important, like Dr. Franklin pointed out, we don't want to use IMEs for purposes of trying to help these people recover, when we maybe we'll have some practitioners out there that do have specific skills to help these people recover, when IMEs will not be the answer on how to work with these claims. And so I know that the department, through the self-insurance section, will be able to help us in getting some of these transfers to care to doctors that have skills in treating people with long COVID. And then I think another thing that I've taken away from this is that one of the things that I hear consistently through different things that I attend is that we underutilize data that is available, that self-insurers provide to the department. And I'm hoping that we again can focus back on information. When the lady that did the epidemiology report didn't have data from self-insurers, I just want to make sure that we're utilizing all the tools that the department has, that in getting information on self-insured claims, that we do send a lot of medical information to the department on our claims, and we just have to figure out a way to get information to the medical directors, researchers, to SHARP. The department does have access to get copies of our claim files via 10-day letters, so that the researchers can look to see if there's information that they want to gather. And so I'm hoping that the next time that we have a colloquium, that we don't hear that they don't have self-insurance data, and that we work hard towards the next colloquium or the report out that we get at Achiever from Dr. Franklin's office, that we have included self-insurance data, and we figured out a way to access that. So again, I'd like to thank everybody that participated. This was a very, very interesting meeting today for me, and I look forward to the next one.
Thank you, Lisa. That I appreciate too all of the takeaways that you mentioned. And I think, you know, we learned a lot today. We learned a lot about what we don't know yet. We learned that we will obviously be continuing to learn a lot, particularly around COVID. But I think we also have more information, right? We've thought about some things, and how, although there's still a lot we don't know, we shouldn't run from it. We shouldn't be scared of it. There's plenty of working on cases that we've all done over the years that is transferable to the work on COVID cases. And a lot of the case law will apply in the same way. I think that the self-insured community as well has received some great information from the presentations that they can use in adjudicating claims, providing information to their doctors to let them know, you know, I think as Deborah said, this is what I need, right? This is the standard that I'm looking for. This is the information that I'm looking for. Help me from a medical standpoint, or like you said, reaching out to their nurse case managers, making sure their nurse case managers are getting this updated information, getting new policies and procedure information that OMD, policies and guidelines that OMD has issued, and just make sure we're all on the same page as to how we are moving forward. And as we've always said, and as this colloquium is based on, we all have the same goal, right? We all want to make sure that injured workers are not harmed further, that they are returning to work, and early intervention, and all of those things. We're all striving for the same thing. So I'm glad that we do have the ability to come together in this way. So again, I also want to thank everyone for attending today. I want to remind everyone, continuing education credits have already been approved for CDMS, as well as claims management credit hours. You will be able to find that information on the WSIA and LNI Self-Insurance websites. You'll also see it on the screen that has been put up. The slide that's been shown on the screen. Remember that the Q&A and the chat logs will be made available, and you will get a survey after this, and we really would appreciate your participation in the survey, as well as input regarding future topics of interest. I made copies of the questions that I indicated that we would get back to everyone on it. I have 3 of them, including the one, Jane, that you listed regarding the Mcot pilot and data. So I will be discussing those questions with my meeting with OMD this week, as well as any debrief that we do for the colloquium. So we will definitely try to make sure that we address the outstanding questions. Also, as you will see on many documents, we have a colloquium email address specifically for feedback on our colloquium or possible future topics of interest to the self-insurance community. And so you will see the email address on the screen, and it is si-colloquium@lni.wa.gov. So with that said, Susan, is there anything further that we need for everyone?
No, everything will be available. All of the compiled PowerPoints in PDF form will be out there, the speaker bios, and this continuing credit information will all be posted on, like you said, the WSIA website and our self-insurance website.
All right. So thank you, everyone. We hope you enjoy the rest of your day and the rest of your week.